განვითარებას, კიდევ უფრო გაძლიერებას, რაც თავისთავად გულისხმობს და ნიშნავს იმას, რომ ეს საფუძველი გახდება ახალი აღმოჩენების, ახალი მიგნებების, ურთიერთგაზიარებისა და შესაბამისად ძალიან ბევრი მეცნიერული სიახლის დანერგვას სოფლიოში და რასაკვირველია საქართველოში. მე წარმატება მინდა უსურვო დღევანდელ სიმპოზიუმს და მინდა გამოთქვა სურვილი და იმედი, რომ ასეთი შეხვედრები ჩვენს უნივერსიტეტში თქვენი შემადგენლობით და უფრო ფართო შემადგენლობით კვლავ გაგრძელდება. დიდი მადლობა.
Thank you very much, Professor. Now I would love to introduce President of Georgian Bariatric Association, Professor Mamuka Gonjulashvili.
Thank you very much. I greet to everyone in this room. I say Manana is organizer this meeting and say thanks to another our guests in other country who left his work, his family. He come to Georgia to help Georgian bariatric and metabolic surgery. May I permission to say several words in Georgian language. დიდი მადლობა მინდა გითხრათ სულ მოგესალმებით ჩემო მეგობრებო. დღევანდელი დღესთვის კიდევ ერთხელ ძალიან დიდ მადლობას ვეუბნები ორგანიზატორებს, განსაკუთრებით ქალბატონ მანანას. დიდი პატივისცემით ამერიკულ ჰოსპიტალს, რომელმაც გუშინ შეგვიფარა და რომელმაც მოგცა საშუალება გვენახა ჩვენი უცხოელი სტუმრების მიერ წარმოებული ოპერაციები. თუმცა ჩვენ დავინახეთ, რომ ძალიან უკან ჩვენ არა ვართ და საკმარისად მაღალ საფეხურზე ვდგევართ. ამ შეკრების მიზანი გახლავთ, მე ასე მგონია, განვითარება ისევ და ისევ საქართველოში მეტაბოლური და ბარიატრიული ქირურგიის და იმედი გვაქვს, რომ ჩვენი მთავრობაც მოგვაქცევს ყურადღებას ამ დარგის მომუშავე ხალხს. მე ველოდები დღესაც რამოდენიმე შეხვედრას დღეს ხვალეზე ჩვენს ხელმძღვანელებთან, ჯანდაცვის სამინისტროთან, რომელმაც ასე ვთქვათ შეიძლება გადახედონ იმ საქმიანობას, რომ ჩვენ ნაკლებ ყურადღებას გვაქცევენ ფინანსურად და არ ეხმარებიან ამ ხალხს. დიდ მადლობას მოგახსენებთ ყველას. იმედი მაქვს, რომ დღე კიდევ ერთხელ ვიძახით დღევანდელი ჩვენი შეხვედრით საქართველოში მეტაბოლური და ბარიატრიული ქირურგია უფრო მაღალ დონეზე იქნება. მადლობა.
Thank you very much, Professor. Now I'm really honored to introduce our conference director and how to say that? He was just making us this proudly announce that Dr. Haris Khwaja, who is really our friend, our provider of this big light in our community, and I'm really giving a word now to the professor. Thank you.
As well as to
Professor Sakhechidze will join us just a few minutes. I proudly announce that we have now first keynote speaker, Professor David Abuladze. I'm very delighted to give him first speech. Thank you very much.
Thank you very much, Manana. Good morning, my colleagues, my friends. It is a pleasure to have this conference here in this very nice building, very nice university. Thank you to the hosts. And I will try to continue my presentation on the Georgian language. And I hope there is simultaneous translation, yes? But anyway, the slides are on English, so it won't be difficult to understand. გამარჯობათ კოლეგებო, პირველ რიგში მადლობას მოვახსენებ ქალბატონ მანანას, პირველ რიგში მადლობას მოვახსენებ გრიგორ ობაქიძის სახელობის უნივერსიტეტს, თბილი მასპინძლობისთვის, ამერიკულ ჰოსპიტალს. ნამდვილად ძალიან საინტერესო კონფერენციაა. დიდი მადლობა ჩვენ სტუმრებს, რომ გამონახეს დრო, გამოძებნეს და ჩამოვიდნენ ჩვენთან. მოხსენების სათაური არის ჩაანაცვლებს კი მაგნიტური ანასტომოზები 2050 წლისთვის ჩვეულებრივ თქვა სტეპლერებს. ნუ მაგითხვაზე პასუხის გაცემა რთულია, იმიტომ რომ 2050 წელს რა მოხდება, მე ვერ გეტყვით, შეიძლება მაგ დროს საერთოდ არ ვიყოთ. მე მაგალითად, თქვენ ღმერთმა გასასრულოთ, ხონდა. მაგრამ ფაქტი არის, რომ მაგნიტური ანასტომოზების ისტორია დაიწყო ჯერ კიდე საბჭოთა კავშირის პერიოდში, კერძოდ ჰქონდათ მცდელობა რუსებს, არა, ინგლისურად არა, ქართულად. საქართველოში ვართ, ორი კაცი ყავს უცხოენოვანი მარტო და. გასაგებია მანანა, მაგრამ საქართველოში ვარ, ქართულად ვკითხულობთ რა, ბოდიშით რა. მაშინ რუსულად წავიკითხებ, გაწყვეტს? ხო და შესაბამისად ბოდიშით ოფიციალური ენა კონფერენციის ინგლისური არისო არსად არ არის მითითებული რა. ამიტომ არცა. ნუ ეხლა აქ სადაც პროგრამა მიჭირავს ხელში. პროგრამაში მე აქ ვერ ხედავ ვერსად, ყოველ შემთხვევაში რომ ოფიციალური ენა ინგლისური იყოს მითითებული. კი ბატონო, არ არის პრობლემა, შემიძლია წავიკითხო, მაგრამ მიმაჩნია რომ წავიკითხო ქართულად. კი ბატონო. ხო, კი ბატონო, არის სიმულტანური თარგმანი და მე იმიტომ ვიკითხე, ხო არის მეთქი და კიო არისო და რახან არის, ნუ არ არის პრობლემა. ჯერ კიდევ მცდელობა იყო მაგნიტური ანასტომოზების კომუნისტების დროს საბჭოთა კავშირში, როდესაც პირველად რუსებმა, ისევე როგორც სტეპლერი პირველად რუსებმა შექმნეს ეს მაგნიტური ანასტომოზების და მაგნიტების გამოყენება პირველად რუსებმა დაიწყეს, მაგრამ საბედნიეროდ ვერ განავითარეს. ნუ არ იყოთ მაგისთვის ტალანტი და ფინანსები. შემდგომ იყო ძალიან ბევრი მცდელობა ეგრეთ წოდებული ბეჭდისებური მაგნიტებით გამოყენება, მაგრამ გამომდინარე იქიდან, რომ იქ ჩაცურება, ეგრეთ წოდებული სლიპიჯი იყო ძალიან ხშირი და ანასტომოზების უკმარისობას იწვევდა, მაგის დავიწყებას მიეცა. პროფესორ მიშელ გარნიეს სახელი ალბათ ყველასთვის ცნობილია, ეს არის ერთ-ერთი ფუძემდებელი ბარიატრიული ქირურგიის მსოფლიოში, კერძოდ სლივასტექტომია მისიდან გამოგონებული ტექნიკაა და მისი დანერგილია. და ასევე ბატონი მიშელი უკვე დაახლოებით 15 წელია მუშაობს მაგნიტების გამოყენებაზე სხვადასხვა ტიპის ანასტომოზებზე, როგორც არის გასტროენტეროანასტომოზები, ენტეროენტეროანასტომოზები, ბილიოდინგესტიური ანასტომოზები და ასე შემდეგ. და ნუ ძირითადში იყო ეს ექსპერიმენტული კვლევები, რომელიც წარმოებდა ცხოველებზე რამოდენიმე ასეული ესე ვთქვათ ღორზე იქნა წარმოებული ამ ანასტომოზების ესე ვთქვათ ექსპერიმენტი და მხოლოდ მას შემდგომ, როდესაც ამ კვლევის ესე იგი ამ მეორე ეტაპმა დაადასტურა, რომ ჩვენ გვაქვს ესე იგი ანასტომოზი, რომელიც არის აბსოლუტურად უსაფრთხო, მერე დაიწყო კლინიკური კვლევა. ნუ კლინიკურ კვლევაში მონაწილეობა მივიღეთ 4 კლინიკამ, ეს იყო კანადაში, მიშელ გარნიე, სადაც მუშაობს, ანტონიო ტორესი მადრიდში, იყო ბელგიაში გიბერნატ კადიერი და საქართველოში კლინიკა ინოვაში გაკეთდა მიშელ გარნიერს და ჩემს მიერ. ხო, მაგრამ ჯერ არ დამიწყია, მანან არ უჭირდება შენი ჯგუფის სწავლება, მაპატია შემოგვივლე რა. პირველად ხო არა ვარ. შესაბამისად, შერჩეული იქნა პაციენტები, ანუ ინგლისურად ქვია ამას MAGD, ანუ magnetic compression duodenal ileostomy, გვერდით გვერდში ანასტომოზი, რომელიც ედება 12 ნაწლავის ბოლქვსა და თეძოს ნაწლავს შორის. შერჩეული იყო პაციენტები, რომელთაც ჰქონდათ ჭარბი-წონა და აღინიშნებოდა ჩაქრიანი დიაბეტი. ნუ ყველა ვიცით, რომ არის ეგეთი ოპერაცია სადი, ერთანასტომოზიანი duodenal ileostomia და კუჭის შუნტირება ბაიპასი, რომელიც როსაც ხდება, ესე ვთქვათ, მლივ ნაწლავზე რუს წესით, ან თუ მინიმ ბაიპასი არის პირით გვერდში ანასტომოზის დადება უშუალოდ ტრეისიდან დაახლოებით 2 მეტრში, ანუ მლივი ნაწლავის 2 მეტრის გამოთიშვა ხდება. და შაქრიანი დიაბეტის კონტროლის მექანიზმი ყველა ვიცით, რომ არის არა მარტო ვთქვათ მალაბსორბციის სისტემა მნიშვნელოვანი, არამედ მნიშვნელოვანი არის თუ რამდენად სწრაფად მოხდება საკვები მასები თეძოს ნაწლავში, რომ მოხდეს GLP-1-ის და GLP-2-ის აქტივაცია. აქედან გამომდინარე, სწორედ სადის ეფექტიც, რომელიც უფრო ძლიერი არის ვთქვათ ბაიპასთან შედარებით დიაბეტის კონტროლში, აიხსნება არა მარტო ვთქვათ უფრო დიდი მალაბსორბციით, არამედ იმით, რომ საკვები გაცილებით უფრო ახლოს არის duodenal-enteral ანასტომოზი ბაუგინის სარკმელთან, ანუ პრაქტიკულად თეძოს ნაწლავზე ედება იქ ანასტომოზი ბაუგინიდან დაახლოებით 3 მეტრში. ანალოგიური მექანიზმია სწორედ ამ დროსაც, როცა duodenal ileostomia ხდება და არა duodenal ionostomia, ვთქვათ, მაშინ საკვების ნაწილი, იმიტომ რომ ეს დაახლოებით მექანიზმით გავს კუჭის ბიპარციალურ რეზექციას, ანუ საკვების დიდი ნაწილი მიდის ისევ ძველ გზაზე, თუმცა მცირე ნაწილი დაახლოებით 30% მიდის აი ამ მოკლე გზაზე. ეს არის, ნუ, ძირითადში აქ არის, ანუ ამ კვლევის მიზნები. უკაცრავად, ამ ლეპტოპზე არ ჩანს ის სლაიდი, იქით რო არ უყურო? ამ ლეპტოპზე ანუ ვერ ვხედავ რაც იქ არის. ვერაა გაიმართლა. ხო და შესაბამისად, ნუ კვლევაში შერჩეული იქნა პაციენტები, მიზანი იყო რომ ნუ დაგვედგინა ამ მაგნიტური ანასტომოზის უსაფრთხოება და ვთქვათ მისი ესე ვთქვათ შესაძლებლობა მისი დადების. ბევრ დროს აქედან ეს არის მაგნიტი, რომელსაც უყურებთ. განსხვავებით, სწორედ აი მიშელ გარნიერის ინოვაცია იყო ის, რომ მან შექმნა მაგნიტი, რომელიც არის სიგრძივი ფორმის, იმიტომ რომ სტეპლერიც როცა კერავს სიგრძეზე, მაგრამ მე მაშინ როცა ხდება ნაკერი, ის იღებს უკვე მრგვალ ფორმას რეალურად. და აქედან გამომდინარე, რომ ამ მაგნიტის პირებს შორის, როგორც ვთქვათ, ჰქონდა ბეჭდისებურ მაგნიტებს ის ნაკლი, რომ იქ ხდებოდა ჩაცურება, ქსოვილის და უკმარისობის განვითარება, აქ პრაქტიკულად არ ხდება. ნუ მექანიზმი როგორ არის? ერთი მაგნიტის შეტანა ხდება თეძოს ნაწლავში, მეორეს მაგნიტის შეტანა ხდება 12 ნაწლავში და როდესაც ეს ნაწლავის სანათური კედლები მიედება ერთმანეთს, ეს მაგნიტებს შორის ეს კედლები იჭრილდება, განიცდის იქ ნეკროს, ესე ვთქვათ კომპრესიულ ნეკროს, რომელიც გრძელდება დაახლოებით 2-3 კვირა. ამ პერიოდში ანთებადი რეაქციის გამო ირგვლივ ვითარდება შემერთებელ ქსოვილოვანი შრე, რომელსაც უკავია ეს ანასტომოზი, ისევე როგორც ნებისმიერი ნაკერის შემთხვევაში ანთების შედეგად ჩამოყალიბებული ნაწიბუროვანი ქსოვილი იჭერს იმ ანასტომოზს. ანუ აქ შედეგები არის, მოიცადეთ გამოვალ მირჩევნია, რომ ეს ზუსტად, ანუ ძირითადი მახასიათებლები ბოდიშით მაპატით, უნდა ვუყურო უბრალოდ იმას, თუ სხვანაირად არ გამო. ძირითადი მახასიათებლები რაც იყო, ესე იგი ამ პაციენტების, იყო რომ ყველას ჰქონდა 5 პაციენტს, ეს არის პირველი 5 სერია, 5 პაციენტის სერია. ყველას ჰქონდა შაქრიანი დიაბეტი, არც ერთს არ ჰქონდა მანამდე განაკეთებიან სლივგასტრექტომია ან სადი ან რომელიმე სხვა პროცედურა და არც ერთთან არ იგეგმებოდა ვთქვათ უახლოესი 1 წლის მანძილზე რაიმე სხვა პროცედურის წარმოება. ეს ხედავთ არის ანუ ინსტრუმენტების ნაკრები არის კათეტერი რომელთაც გასტროსკოპში შედის ეს გასტროსკოპზე ფიქსირდება ეს მაგნიტი და ქვემოთ ამას პოინტერი არ აქვს. ნუ სულ ქვემოთ არის ინსტრუმენტი რომელთაც ჩვენ მაგნიტს ვასრიალებთ მუცელში ვიდეოზე ნახავთ. აი აქ არის სქემატური აღწერილობა. აი აქ მივალ ახლოს ეკრანთან უფრო კარგად დაინახავთ. შესაბამისად ხდება პირველი მაგნიტის ჩატანა, თუმცა ეხლა უკვე გვაქვს ტექნიკა ისეთი მაგნიტია, რომელიც იყლაპება პირდაპირ ტრეიცის იოგის გასწვრივ, მისი ფიქსაცია ტრეიცის იოგთან იმით ნაწლავის დამჭერით. შემდგომ ხდება ამ მაგნიტის, ესე ვთქვათ, ჩასრიალება ბაუგინიდან 2 მეტრ ნახევარში და ეს მიტანა ინსტრუმენტებით მეორე მაგნიტთან, რომელიც არის 12 გუჯა ნაწლავში. და დროთა განმავლობაში აქ ყალიბდება ესეთი ანასტომოზი. ეხლა უკვე ჩვენ გვაქვს რეალურად ჩასაყლაპი მაგნიტი, ძალიან ადვილად ყლაპავს პაციენტი. ზეიდან ვაყოლებთ მინერალურ ზეთს, იგივე რომელიც აფთიაქებში იყიდება თავისუფლად, თუმცა ცოტა დეფიციტშია. ვაზელინის ზეთი სახელით არის ჩვენთან ცნობილი. დაახლოებით 50 მილილიტრი ჭირდება იმისთვის, რომ ჩაიყლაპოს. სადღაც 2 საათში ვნახულობთ რენტგენოლოგიურად, ანუ ეს მაგნიტი, რა თქმა უნდა, რკინ მეტალია და რენტგენოკონტრასტულია და უკვე გადასული არის ტრეიცის იოგის ლატერალისა დისტალურად და შემდგომ იწყება ლაპარასკოპიული ეტაპი ოპერაციის. ნუ ლაპარასკოპიული ეტაპზე პირველ რიგში ხდება ბადექონის, ესე ვთქვათ, გახსნა იმისათვის, რომ ადვილად ანასტომოზი არ დაიჭიმოს და გადაზომვა ხდება 2 მეტრ ნახევრის ბაუგინიდან უკან. მას შემდგომ რაც მივახსენებთ იმ ადგილს, სადაც ანასტომოზი უნდა დაედოს, ხდება მიდამოსი მონიშნა კლიპებით, 2 კლიპი ედება ერთ მხარეს, 2 კლიპი მეორე მხარეს. ეს მონიშნა ძალიან დიდი მნიშვნელობა არა მარტო იმისთვის, რომ ვიცოდეთ ზუსტად სად გავჩერდეთ მაგნიტი, სად მივიტანოთ, არამედ შემდგომი კონტროლისთვის, იმიტომ რომ კლიპები არის რენტგენოკონტრასტული და ჩვენ როდესაც ვაკონტროლებთ შემდგომ რენტგენოლოგიურად ოპერაციის მეორე დღეს ვნახულობთ როგორ დგას, ნუ ჩვენ შეგვიძლია ზუსტად ვიცოდეთ, რომ ის ანასტომოზის მიდამო რენტგენოლოგიურად სად მდებარეობს. ნუ შემდგომ რომ რა პრობლემა იყოს, თქვა და დაგჭირდეს ბარიუმით ან კომპიუტერული ტომოგრაფით გამოკვლევა, ზუსტად ვიცოდეთ სად არის ანასტომოზი, იმიტომ რომ პრაქტიკულად იქ განსხვავებით სტეპლერის ანასტომოზებიდან იქ პირდაპირ სტეპლები ჩანს და იცის სად არის ანასტომოზი და აქ არანაირი ნაკერი და არანაირი მეტალი უშუალოდ ანასტომოზში აღარ რჩება. ეს ხედავთ, რომ არის ინსტრუმენტი, რომელიც შეტანილი არის 12 მმ-იანი ტროაკარიდან, ამაზედაც თავზე მაგნიტი არის დამაგრებული უშუალოდ და ერთი მაგნიტი არის ქვემოთ უკვე ნაწლავში, რომელიც გადაყლაპა პაციენტმა. და ხდება მისი გასრიალება. გამომდინარე იქიდან, რომ მინერალური ზეთი აქვს დალეული, საკმაოდ ადვილად სრიალებს. ეს შეიძლება ითქვას, რომ ოპერაციის ყველაზე, ესე ვთქვათ, სწრაფი ეტაპია. ყველაზე დიდი ეტაპი არის ეს სწორედ ნაწლავის გადაზომვის ეტაპი, რომელსაც მე აქვს დაახლოებით ოპერაციის ხანგრძლივობის თითქმის 60%. მას შემდგომ, რაც მივიტანთ ამ მაგნიტს იმ ადგილზე, სადაც, ესე ვთქვათ, ჩვენ მონიშნული გვაქვს, ანუ ეს არის ბაუგინიდან 2 მეტრ ნახევარში, და დავაფიქსირებთ, რომ იქ ვართ, მერე იწყებს ენდოსკოპისტი მეორე მაგნიტის ჩატანას უკვე საყლაპავი ენდოსკოპის მეშვეობით 12 გუჯა ნაწლავში. ბავშვობაში ალბათ ყველას გვითამაშია მაგნიტებით ქაღალდზე, როცა ვასრიალებთ, ერთი მაგნიტი ქვემოთ არის, ერთი მე და ვითომ ესეთ ფოკუსებს ვაკეთებთ, დაახლოებით მსგავსი ფოკუსივით კეთდება აქაც. უპირატესობა მაგნიტურ ანასტომოზებს რა აქვს ახლა სანამ აი ახლა ეს პირდაპირ გეტყვით უკვე შეტანილი არის გასტროსკოპის ხედავთ რომ ციმციმებს იქ შუქი შეტანილი არის 12 გუჯა ნაწლავში ვამოწმებთ რა თქმა უნდა მანამ სანამ მივამაგრებთ ხომ არ არის როტაცია ანუ მანიპულაციების დროს ხო არ მოხდა ჯორჯლის მოტრიალება და ესეც არ არის მარტივი შესატანი სხვა შორის უნდა ფრთხილად ვიყოთ რომ ნაწლავის თვლიანობა არ დაირღვეს მაგრამ ისე არის გათვლილი რომ აი ამ ინსტრუმენტის მაგნიტური ძალა და მაგნიტების მაგნიტური ძალა განსხვავდება ერთმანეთისაგან აქ გაცილებით ნაკლებია და შესაბამისად როდესაც ხდება მიტანა აი ესენი ეწებებიან უკვე ერთი არის ეს 12 გუჯას პილორუს როგორც კი გაცდება იქვე და მეორე არის ნაწლავის სანათურში მას შემდგომ რაც ეს დაფიქსირდება მე ვეუბნებით ენდოსკოპის რომ მოხსნას ენდოსკოპიდან გაანთავისუფლოს მაგნიტი. იმისთვის რომ ჩვენ შევძლოთ მე ამ ანასტომოზის მიდამოს манипуლირება, ანუ გადატანა შესაძლებელი არის, აი რომ მიაწვევი აქეთ ამ მხარეს, იქით ამ მხარეს 12 გოჯაშიც მიდის და ზუსტად იმ ადგილას დააყენებს, სადაც სურვილი გაქვს. იმიტომ რომ კერძოდ არ უნდა ჩასდეს ბოქს, რომ ფატერის დრულს არ შეუქმნას პრობლემა და ასევე არ უნდა იყოს პილორუსზე გადმოსული, რომ შესაბამისად პილორუსის თლიანობა არ დაირღვეს. აუცილებლად ხდება მეზენტერიალური ფანჯრის დახურვა იმისათვის, ეგრეთ წოდებული პედერსენის დეფექტის, რომ არ მოხდეს ან შემოგრეხა ამ ანასტომოზის, ან კიდე ნაწლავის ჩაჭედვა შიგნით. დაახლოებით ესეთი სქემა არის მაგდის ფორმაციის. შემდგომი კვლევები, რაც იქნა წარმოებული, იყო 11 პაციენტი კიდე, ოღონდ დაბალი სხეულის მას ინდექსით, ანუ მას ინდექსი 29-დან 32-მდე, რომელთაც გაუკეთა შაქრიანი დიაბეტით, რომელთაც გაუკეთა ეს ოპერაცია კუჭის რეზექციის გარეშე. ანუ იყო 35 წელს ზემოთ, ვინც იყო პაციენტი, იმათ სლივი გასტრექტომიას გაუკეთდა მაგდის დადების მერე, ხოლო და პრაქტიკულად მივიღეთ სადის ეფექტი. ხოლო ამ შემთხვევაში ეს თვისობრივად ვაფშე ახალი ტიპის ოპერაცია, ანუ იმ დაბალი სხეულის მას ინდექსზე, როდესაც შენ კალორაჟის შემცირება უკვე საშიში არის და რომელიც ჯერჯერობით ISO-ს გაიდლაინებში არ არის შეტანილი როგორც მეტაბოლური ოპერაცია, ანუ დაბალი მასის ინდექსი 32-ზე დაბალი, მაგრამ ტიპი 2 შაქრიანი დიაბეტი მეტაბოლური სინდრომით, ინსულინ რეზისტენტობით და მაღალი ცეპეპტიდით, სადაც შეიძლება ჩაითვალოს, რომ მეტაბოლური ეფექტი გვაქვს და ესენი არიან პასუხები, სადაც ჩვენ ეფექტურად ხმარობენ ჩვენი ენდოკრინოლოგები, იგივე სემაგლუტიდის პრეპარატს, ან უნჯაროს, ან თქვათ მაღალი დოზებით CO4-ს და ფორსიგას. ეს არის სურათი მეორე დღეს, ხედავთ, აი აქ არის კლიპები, ჩანს რომ ეს არის ანასტომოზის მიდამო და მაგნიტები. ეს არის უკვე დაახლოებით 3-4 კვირის მერე, ხედავთ რომ მაგნიტი უკვე დაძრული არის, ანუ იმ ხვრელში ჩამოვიდა და აქ ამ შემთხვევაში ცეკუნშია. აი აქ არის რენტგენოლოგიურად ხედავთ რომ ეს არის 12 ჯანაწლავისკენ წამოვალი გზა, ეს არის კიდე ახალი გზა. ანუ 15 პაციენტზე გაკეთდა ყველა შემთხვევაში გართულების გარეშე, არანაირი ჩარევა არ დაგჭირებია იმისათვის რომ მაგნიტი გამოსულიყო გარეთ, თქვათ ან ენდოსკოპის დახმარებით და რადიოგრაფიულად ყველა შემთხვევაში იყო უნაკლო ანასტომოზები. ეს არის უკვე ბოლოთაობის მაგნეტი, რომელიც ეხლა თებერვლიდან შემოვა საქართველოში და დავიწყეთ ჩვენ უკვე ამის მოხმარებას. FDA მოგცა ივლისში ამაზე თანხმობა მაგნიტის გამოყენებაზე, რომელსაც აქვს ბიოფრაგმენტარებადი, ესე ვთქვათ, გარსი გარედან და უფრო დიდია ზომაში. ანუ წინა იყო 3 სანტიმეტრი, ამის ზომა არის 4 სანტიმეტრი სიგრძე. და ახასიათებს უფრო იმიტომ რომ იქ იყო იმ მაგნიტებზე ორ შემთხვევაში რომ 2 თვე დაჭირდა ანასტომოზის ჩამოყალიბებას და ეს ბიოფრაგმენტარებადი შრე საშუალებას გვაძლევს რომ დაახლოებით 4 კვირაში მაქსიმუმ ჩამოყალიბდეს ანასტომოზი. ეს არის ანასტომოზის სურათი ენდოსკოპიური ოპერაციიდან 1 წლის მერე ხედავთ რომ ეს არის ანასტომოზი უშუალოდ, ანუ წრული ნაწლავის მარყუჟი ჩანს და იქით გრძელდება უკვე 12 გუჯა ნაწლავი. იმ პაციენტებში, იმ 15 პაციენტში, სადაც ჩვენ სლივის გარეშე გაკეთდა ოპერაციები, საშუალო მასის ინდექსი იყო 33 და შესაბამისად ეხლა გაჩვენებთ შაქრის და წონის კონტროლის სქემებს. ეს იყო, ანუ წონის კლება. ანუ რეალურად პირველი ეს არის პროცენტული მაჩვენებელი იმ პაციენტებში, სადაც თქვათ ჩვენ იყო სხეულის მასის ინდექსი 35-ზე მაღალი, ხოლო ქვემოთ არის ჩვენთან, სადაც იყო შედარებით დაბალი სხეულის მასის ინდექსი, მაგრამ 1 წლის თავზე 11.4% ჭარბი წონის მაინც დაკლებული აქვს. ანუ კერძოდ პრაქტიკულად სხეულის მასის ინდექსი 26-27-მდე ჩამოვიდა იმ პაციენტებშიც, სადაც 31 იყო თავიდან სხეულის მასის ინდექსი. გლიკოზირებული ჰემოგლობინის კლებაც ასევე მივიღეთ ყველა შემთხვევაში, ჩამოსული არის 6 და 4-მდე, 7 და 5-დან საშუალო მაჩვენებლიდან, ხოლო რაც შეეხება შაქრის კლებაც, ესე იგი საშუალო 168 თუ იყო იმ პაციენტებში, ჩამოსული არის 1 წლის თავზე 123-მდე. გართულებებს რაც შეეხება, არც ერთი არ იყო სერიოზული გართულება, კლავიენდინოს კლასიფიკაციით ტიპი 1, ტიპი 2 იყო გართულება ძირითადში, ორ შემთხვევაში იყო grade 3, რომელსაც დაჭირდა სტაციონარული მკურნალობა, მხოლოდ კონსერვატიული, ეს იყო დუოდენიტების შემთხვევები. როგორც დასკვნაში ჩვენ შეიძლება რომ მაგნიტი გამოყენებული იქნას როგორც უსაფრთხო ანასტომოზის სახით კუჭნაწლავის ტრაქტში, ყველა შემთხვევაში ტექნიკურად ძალიან მარტივი შესასრულებელია და learning curve ახლა რაც ჩვენ დავაკვირდით, მაგალითად უკვე ახლობით პირველი 10 ოპერაცია რო ვეხმარებოდი ბატონ მიშელ გარნიეს, მე შემდგომი 5 უკვე დამოუკიდებლად გავაკეთე, ან სწრაფად ხდება სწავლება, რა თქმა უნდა ქირურგი უნდა იყოს გამოცდილი როგორც ლაპაროსკოპიულ ქირურგიაში, ასევე გამოცდილი ენდოსკოპისტი უნდა ყავდეს, რომელიც ვთქვათ 12 ნაწლავზე და ფატერის რძილზე კარგად მუშაობს გვერდში. და როგორც შედეგება აჩვენა, რომ კუჭის რეზექციის გარეშეც ისეთ პაციენტებში, სადაც ჩვენ ნაჩვენები გვაქვს მეტაბოლური ჩარევა, ანუ არ არის დიაბეტის აუტოიმუნური ფორმა, არის შედარებით კონტროლირებადი მედიკამენტებით, მაგრამ გვაქვს მეტაბოლური სინდრომი, თავისი ღვიძლის გაცხიმოვნების ლიპიდური სპექტრის დისლიპიდემიით და ესე ვთქვათ, სხეულის მასის ინდექსი არ არის ძალიან მაღალი და არ გვჭირდება ესე ვთქვათ კალორაჟის მკვეთრი შემცირება და მხოლოდ ამ მეტაბოლიზმზე მოქმედებით ჩვენ შეგვიძლია მივიღოთ ეფექტი დიაბეტის კონტროლის, ეფექტურია მაგ შემთხვევებში. დიდი მადლობა ყურადღებისთვის და კითხვაზე იმაზე 50 წელს ჩაანაცვლებს თუ არა, მაგ ნამდვილად არ ვიცი. თუმცა ესე ვთქვათ, მცდელობები გრძელდება. დიდი მადლობა.
დიდი მადლობა ბატონო დავით, მოგესალმებით ყველას დილამშვიდობის. ძალიან საინტერესო იყო, თუმცა განხილვებზე ჩვენ მერე გვექნება დისკუსია, ამიტომ ეხლა შემდეგ მომხსენებელს გამოაცხადებს კალბატონი მანანა.
Proudly introduce Professor Surendra Ugale. I have to remind everyone now, please, our conversation, let's speak in English and have in English, and 10 minutes reglement, please, to follow our agenda, okay? Thank you very much. It was really interesting and very just, I think, genius creation for metabolic surgery. And thank you very much, Professor Abuladze. Thank you very much once again.
Gabrajoba. So I thank Dr. Manana and IBC for this invite. It's my second time in your city and country, and I was here about 11 years ago with Mamuka, Manana, and Nico, who's not here with us now. So it's a pleasure to be back here in Tbilisi in Georgia, and thank you for having me here, and XNY for taking care of us. So I'll go to the topic about management for reactive hypoglycemia after Roux-en-Y gastric bypass. I have no conflict of interest. Now, reactive hypoglycemia is also termed as post-bariatric surgery hypoglycemia, late dumping syndrome, or postprandial hyperinsulinemic hypoglycemia. So what happens to glucose once it goes in the system and it's absorbed? It goes mostly to the muscle cells, the liver cells, and fat cells. And then with the ingestion and absorption, it depends on whether you have simple carbohydrates or complex. It depends on the transit, the gastric emptying, which is influenced by various factors, and the digestion, and the intestinal glucose uptake. So then there's entry into the portal blood, and a delivery to the liver, then the periphery, and a disposal of the glucose. So how do you diagnose reactive hypoglycemia? Clinically, you could have symptoms which are adrenergic or neuroglycopenic. And there are various, there is cholinergic also, and so from various symptoms you can suspect reactive hypoglycemia. Mainly patients are uncomfortable after their meals, some have palpitations, some have giddiness and weakness, and there is sweating. So, but there could be a a combination of any of these symptoms. The proof can come through continuous glucose monitoring systems where you can actually track this and make a diagnosis when you have a suspicion, but you cannot catch the glucose when you just do a blood sampling and a test in the lab. So one of the best ways is to get this where you can actually see which are the times when the glucose drops to low levels. Now, to understand the problem, this is compounded by consuming large meals of simple sugars. So therefore, medical nutrition obviously should become the cornerstone for prevention of this and for dealing with this. The goal, of course, is to reduce high surges in the postprandial glucose because that is what triggers high insulin, and then there's a reactive hypoglycemia. So this is the syndrome of the postprandial hyperinsulinemic hypoglycemia. When there's rapid emptying from the stomach pouch to the jejunal through the anastomosis, changes in the glucose, and this is also part of the weight loss independent glycemic effects of the RYGB. But the exaggerated effect can manifest even several years post-surgery. So it's not that it'll come very soon after surgery. And a larger systemic appearance of the ingested glucose and greater post-meal secretion of insulin and GLP-1. Because we are looking for the incretin effects, but when it's exaggerated, it's a problem. Now, how much is the incidence really? When you do a OGTT test, you find a prevalence reported by COP of 25%. Smaller studies using CGM have reported even as much as 55 to 75% of the patients, because as I told you, this can track it real time across a 24-hour cycle, and therefore it catches many more of these episodes. Now, a randomized controlled trial found, surprisingly, no significant difference in the occurrence of hypoglycemia after sleeve, also as compared with a Roux-en-Y gastric bypass. The only thing is, Roux-en-Y gastric bypass was associated with more severe episodes, and therefore it was more clinically significant and more troublesome for the patient. So in a study using CGMS, nocturnal asymptomatic hypoglycemia reported to occur more frequently after sleep, but it is milder. The one with Roux-en-Y gastric bypass is more often with postprandial and more symptomatic, severe symptomatic hypoglycemic events. So this shows you how there are changes in glucose delivery and glucose utilization, which explains the pathogenesis of the hypoglycemia. Depends on the glycemic gradient across the liver. The gastric bypass effect comes into play, and then there's the pathophysiological defect also that's specific. So treatment options can be utilized based on the pathogenic factors. So initially, of course, there should be a conservative management. And dietary management is the key, where the counseling is a comprehensive one, where they advise adequate protein and fiber intake to minimize the glucose fluctuations. Acarbose is the most commonly used medication which slows down carbohydrate absorption and would be used or may be necessary along with the dietary modifications. So with nutrition, there is a 10-point nutritional plan to try and prevent, where you control portions of carbohydrate, choose low glycemic carbohydrates, avoid the high glycemic ones, include the healthy fats in each meal or snack, emphasize on optimal protein intake, space your meals 3 to 4 hours apart, avoid consuming liquids with meals, avoid alcohol and caffeine, and maintain the post-bariatric vitamin and mineral intake. So acarbose, the mechanism of action, as it's called the starch blocker, it competitively inhibits the enzyme alpha-glucosidase in the intestinal brush border, that is, which is responsible for breaking down the complex carbs into glucose. So it slows down the digestion and absorption of carbohydrates, and therefore there is a slower rise in blood sugar levels. Now there is a competitive inhibition, and this binds to the active site of the enzyme, preventing the normal substrate from binding and being broken down. The other medications used are also miglitol and voglibose. And even though these drugs act similarly, there are subtle differences between these. So, but out of all, generally we find that acarbose seems to be most effective, and this inhibits the pancreatic alpha amylase also, in addition to alpha glucosidase. So the strategies for dealing with these controlled portions of low glycemic index carbs, avoid the rapidly absorbed carbs, adjustment of timing and meals, and attention to personal and cultural barriers to these implementation, which is the influence on the choice of foods that people would have at home, choice of healthy, heart-healthy fats and protein. So even with strict compliance, usually additional medical treatment may be required to reduce the glucose spikes and therefore avoid the stimulus for the insulin secretion. Now intervention is needed when all conservative methods fail. So you could have endoscopic intervention or surgical laparoscopic intervention. First, one would do is, of course, use CGMS and confirm and ensure to find out when these fluctuations are happening. And then if you do a 3D CT volumetry, you can actually see how the bowel and the pouch area are dilated, how the food may be transiting very rapidly and dumping and leading to the whole process. So you can do a gastric pouch restriction over here, which is narrowing the opening of the gastric pouch to slow down the emptying of food and slow down the glucose absorption. And therefore, you potentially can reduce the severity of these hypoglycemic episodes. So one can do an outlet repair, which is a transoral revision endoscopically. APC, the argon plasma, can be used to fulgurate the margins of the anastomosis, and then using an overstitch suturing, one can reduce the size of the opening. This is courtesy Christine Stier from Germany, as they are doing a lot of work in this matter. And here you can see how the fulgurated area is then taken with the endostitch and the suture with the overstitch, and the opening gets narrowed, and you can see the results 4 weeks later, and even 3 months later. At times, sometimes the opening again starts to expand, and you may need a redo endoscopic suturing again. And on the CGMS, you get the proof that that before this was done, how the glucose is out of control and really low in 60% of the time. and later it's only 5% of the time. So it is significantly reduced. So this can be a very useful tool, and of course it's minimally invasive, so that's an advantage. Now surgical intervention, again the aim is to slow down the rapid emptying, and this is used for patients who have severe symptomatic hypoglycemia that is not managed with dietary and medical treatment. The downside, of course, is that when you do certain intervention, especially the reversal, there is a great potential for weight regain and resurgence of all the previous symptoms the patient had come and underwent surgery. Of course, if you convert this into another procedure, you can prevent any weight regains and the problem. So RYGB reversal is the most drastic last step, and of course is most effective to treat the severe postprandial hypoglycemia, but as I mentioned, you have the issues of weight regain. So, and that is significant, and it negates all the benefits of the operation that was done initially. Now, a temporary measure when you have a severe situation, if you just want to tide over the crisis, you can insert a G-tube in the remnant, and in this way you can bring about a control and a stabilization of glucose levels for the time being till you take definitive action. Now I wanted to show you a short video. Can we play the video, please? So anyway, if he finds the video, in conclusion, hypoglycemia is much more common than we think. Most times it is not troublesome. So conservative treatment is always used first with dietary and pharma. Endoscopic is minimally invasive for outlet restriction, and surgical when we are forced to as the last resort. It is either a reversal of the procedure or convert to a sleeve plus procedure. So we can do a SADI or we can convert to a DS, and I had a short video if they're able to play it. Otherwise, thank you very much.
Thank you, Professor Surendran. Thank you very much. Okay, discuss will be later.
I would love now to introduce Professor Madonna Sekhniashvili. Very interesting topic. Thank you, Professor. It was excellent. Thank you very much once again.
Hello. First of all, I'd like to thank Dr. Manana for inviting me. It is an honor for me to be invited at this conference. My today's talk is dedicating to reviewing the spectrum of neurological complications after bariatric surgery and to drawing attention to this problem, as with the increasing use of bariatric interventions, the neurological complications have become quite common. I'll briefly touch on the main aspects, and then I will present several typical cases examined by me over the last year. The good news is that all of these complications can be avoided with proper nutritional care. So many patients pursue this operation as a cosmetic intervention for the aesthetic purposes, and technically correctly performed operation is perceived as a success for the surgeon. But besides performing excellent operations in Georgia, which our Georgian surgeons definitely do, and besides positive effects of indicated surgery, we should remind the patient that interference with physiological mechanisms may have sometimes irreversible and negative impact on various aspects of health, and that their care does not end after discharge from the clinic, but proper nutritional monitoring is very important. This is more or less regulated in developed countries, therefore data on this topic is difficult to find in the literature. In our Georgian centers, it turned out that there are some late neurologic complications. And Therefore, I and my fellow, Anna Chokhonelidze, have planned already prospective study on this topic, and we would like to encourage our colleagues to join us for the multi-center trial. The broad spectrum of neurological complications were reported in up to 3 to 16% of cases. And since there is no large field study, the real frequency may be even higher. They affect mostly the peripheral nervous system and sometimes also, of course, CNS. And physicians need to be alerted to think about those conditions as sometimes some clinical signs are perceived as a psychogenic by some colleagues, and they need at least proper neurologic consultation to be differentiated or verified. And some of these complications may occur in 3 to 20 months even after the surgery. These neurological complications occur predominantly due to inadequate nutrition and may take quite a while to become symptomatic. There should be early activities, including to devise a diet with follow-up, and failure to get recommended supplementation can lead to vitamin deficiency and poor mineral and protein supply. The profound reduction in mucosa surface may lead to the secondary malabsorption, as you know, and the gastrointestinal disorders, including frequent vomiting, will accelerate the malnutrition. Over the last year, I have diagnosed the neurological complications in 15 patients. Almost all affected patients had protracted vomiting, the most common symptom that occur in up to 1/3 of all operated cases. And 6 of them had polyneuropathy, 2 had Wernicke encephalopathy, and 7 had peroneal nerve compression at the fibula. The individual severity between the patients were different, and we did not have a precise information as to the magnitude of the surgery and had no complete information about the diet post-surgery. In the patient interviews, it revealed that all of them had low intake of food and lacking substitution of vitamins and high energy nutrition. And to determine deficiency, unfortunately, was difficult due to different reasons. In fact, our preliminary analysis suggests that those patients who has followed proper advice from experienced dietitians develop neurological complications less common. If verified in a prospective study, it may suggest that complications may be indeed less pronounced with appropriate substitution of vitamins. And next I'm going to present these complications. So first is the post-bariatric polyneuropathy, which is the most common neurological complications seen after the surgery. And the manifestation is mostly weakness, proximal weakness in their legs, slapping gait. They cannot stand up independently. They have pain, burning in feet that may spread to the arms as well. And the most authors suggest that mechanisms related to development peripheral neuropathy should be nutritional deficiency. We had 6 patients with such kind of complaints, and their median age was 30, and they developed these complications within first 2 to 6 months from the surgery. And all of them had sleeve gastrectomy, and important is that all of them had positive outcome, but long-lasting. And according to the literature, this outcome may be complete in only 85% of cases. And this patient is 1 out of 6. She has lost 40 kilograms within 2 months. She had frequent vomiting after the surgery, and she developed typical complaints described, so proximal weakness, weakness in her feet as well, and pain and burning sensation. Please, can you start the video? And we see, I asked her to walk on heels, and she cannot do it. I don't see it, okay. And she tries to walk on tiptoe, and it is also not possible. Then she tries to sit down, and she is not confident to manage it. So this is typical picture seen with such patients. This patient recovered fully, but it took for her up to 1 year. At the moment, she is pregnant for twins. Next complication I'd like to emphasize is peroneal nerve compression at fibular head. I have examined 7 patients within 1 year after bariatric surgery. Half of them had sleeve and another 4 had bypass surgery. And most of these complications occur in up to 9 months from the operation, when patients have lost already 40 to 45 kilograms and developed new habit of crossing their legs because it was impossible for them to do so before. And due to this habit, we see that the common peroneal nerve is compressed at the fibular head, and I use nerve conduction study as a gold standard for diagnosing. We put the electrodes on the foot, on the muscle, and stimulate peroneal nerve at the ankle and see normal response, then stimulate it at the fibular head, again with normal response. And when we stimulate at fibular, popliteal level, we see drop of amplitude, and we call it nerve conduction block, which means there is focal demyelination due to compression of peroneal nerve. And it's in such kind of cases, please turn. We use visualization, mostly ultrasound or MR neurography. And we visualize the common peroneal nerve, which is thick and swollen at this segment, and we compare it to the contralateral side, where nerve is too small to see it. So, next patient I'm going to show you has, please, next slide. He has both complications, polyneuropathy with proximal weakness. He needed support to stand up and walk, and also left-sided foot drop, so peroneal nerve compression. Please start the video. His walking is affected. We see the foot drop on the left side as well. And this patient was recommended to start with rehabilitation program, with physiotherapy, with nutritional supplementation, local application of steroids. And after 3 months, we see he does not need support anymore, but foot drop on the left side is still to see, and especially it's easy to hear the sound of steppage gait. According to this experience, next slide, please. I'm going to share another 2 cases. Both ladies have typical complaints of foot drop on both head on the right side. Please start the video. And I ask her to walk on heels, and with the right side, it's impossible. It's easy to screen for patients who has numbness in their legs, and mostly the sensory abnormalities are distributed in the superficial peroneal nerve region. And the next patient, same with this lady, right-sided, she is not able to dorsiflex the foot. In both cases, recovery was, outcome was positive, but, yes, but the second patient needed surgical decompression of peroneal nerve, which we did in 3 patients out of 7. Because when we check the muscle, there is acute denervation, the sign that muscle is getting atrophied. So in order to avoid this atrophy, we rather make surgical decompression of peroneal nerve. Next slide, please. So, the recommendation in such cases is, in order to avoid this complication, please inform the patient not crossing their legs, and this is the correct habit of sitting, and to wear high heels is not part of the recommendation. Next, please. Next patient I'm going to report is, I have examined her on the intensive care unit of one hospital, and she had complaints of double vision, confusion, imbalance, difficult speaking, swallowing, and breathing. And she had 3 months previously, she had sleeve gastrectomy and developed these complications insidiously after frequent vomiting, and clinical diagnosis of Wernicke encephalopathy, so-called bariatric beriberi, was made. To determine B1 level was impossible in this acute situation, so the therapy was started, but despite it, patient struggled on the ICU for 3 months with 3 episodes of sepsis and with decompensated neurological and polyorganic changes. She was admitted after 3 months to the rehabilitation center with tetraparesis and loss of insights, but later she appeared to the palliative care unit, unfortunately. By the way, recently I had similar case, absolutely same clinically, but this patient did not have bariatric intervention, but she was pregnant and had frequent vomiting within the first trimester. So these kind of complications are not directly related to the surgery, but due to the nutritional deficiency, of course. And please start the video. This patient has nystagmus, most common neurological signs seen during the Wernicke encephalopathy, and the restriction of eyeball movement. She's trying to follow my finger, and the right eye is not abducting at the point. So absolutely. So next case. This is positive case of Wernicke encephalopathy again. This guy presented to us with double vision, confusion, general weakness, imbalance, and dizziness after 5 days from the start of the symptoms, and he was operated 2 months previously with frequent vomiting again and lack of fluid replacement. And clinically, please video. I asked him to follow my finger, but abduction on the right side is impossible. And the same is to the left side, we see. And nystagmus is also here. So again, it is another case of Wernicke encephalopathy. Of course, we did not determine B1 because it would take time. So we just started with the intravenous infusion of B12 vitamin 1000 microgram and 300 milligram of B1 3 times a day. And next day, we see the patient recovered. So the amplitude of eye movement was better within 1 day. So this is the positive case, and this is an example that if we recognize all of these symptoms as early as possible, we can avoid some difficult complications. Okay, we also performed MRI, and we found some changes typical for Wernicke encephalopathy in the area postrema, which is responsible for high blood pressure as well, which was experienced by this patient. Next. So, what can we do about these complications? The recommendations are based on experts' opinion and observation, not on randomized trials. Although clear cause-effect relation cannot be established for those cases, the cumulative literature on the subject makes it important to warn the patient about potential risks, and like awareness programs educating them should be considered. Guidelines and follow-up schedules should be planned and practiced, including surgeon, family physician, dietitian, and neurological complications can only be avoided through proper nutritional monitoring, individually, pre- and post-surgically, at 3, 6, and 12 months, and then annually. And in case of vomiting, diet modification, fluid replacement, and in case of deficiency, nutritional therapy, together with patient motivation, is crucial. Thank you very much for your attention.
Excellent presentation.
Excellent presentation. Thank you very much. Thank you. We will discuss about this because it's very important things for all of the bariatric surgeons. Thank you.
I'm delighted again to now say that we have a coffee break. This will take 25 minutes. Thank you very much. See you soon.
Tired of ads in games too? Check out Hero Wars. It's one of the best ad-free games out there right now.
არტურ იენსენი. 64-ში ყველაფერი ისე არ არის, როგორც გეუბნებიან. სიკვდილის შემდეგ
მეგობრებო, გთხოვთ დაუბრუნდეთ საკონფერენციო დარბაზს და დავიწყოთ, გავაგრძელოთ უпроსტად.
How are you today? Everything is okay? Yes, we enjoyed yesterday.
Okay.
I continued my night in the casino. It was great. Thank you.
Today we meeting again.
Yes, thank you.
მოგესალმებით კიდევ ერთხელ. მოდით გავაგრძელოთ ჩვენი მოხსენებები. ამ ეტაპისთვის უნდა ჩართულიყო ბატონი ენდრიუ გამპსი საფრანგეთიდან, მაგრამ რაღაც კონტაქტზე ვერ გამოდის, ამიტომ ჩვენ ვთხოვოთ უსტაფას ვთხოვოთ. ამიტომ ვთხოვოთ ხა პროფესორ მუსტაფა ალოუჩს დიახ, რომელიც არის ლიბანონიდან. Please.
I will not go for too much introductions because we have to thank everybody that helped us, but definitely I should always mention Manana, who is our guide and our lovely introducer to this nice event. What I will be talking about is a problem which is haunting us and will haunt us for at least the next decade concerning bariatric surgery. We are inheriting the era of the bands where everyone had a band. And everyone asked for a band. And now we are seeing the results. And this is why I said it's about the hostile gastric fundus, slipped, infected, migrated band, what to do to prevent leaks in revisions. So this is what we will be talking about in the next, okay. So complications are, bands are fraught with complications. There are minor complications, major complications, but we'll be concentrating on slippage and on the migration. So everyone knows about the rise and fall of bands. In the 1990s, everyone was, we thought that this was a miracle treatment for obesity before it was constructed for esophageal reflux, GE reflux, and then later people thought that it might help, and it did help to some extent. It was a magic treatment for obesity. However, later with time we started noticing that probably the procedure that was propagated as the least complicated and with the least complications has shown that it has the most complications lifetime, and it never stops until you remove it, and sometimes still you have complications following that. So the main indication this is a Polish revision, a Polish study in 2023, and the main indication for revision by surgery is in AGB was weight regain. However, we'll not be talking about this issue. And again, some minor complications can be managed by deflation, and major ones definitely will need intervention and surgery. And surely, most of the times, it is an emergency surgery, especially when you have acute slippage and possible necrosis. And this is what we are talking about. This is the well-known angle that we usually measure and we see. And however, even this can be be misleading, because even if you have an angle in the band, but when you go and do the studies, you will see that it's worse, much worse than this. And this is the ugly picture that you see when you open up. Again, to make sure, this is a great angle, but you see it's very far away from the diaphragm. So definitely you go by the clinical picture. If the patient is not doing well, then you have to do the esophagogram, gastroesophagogram, and you'll see that this is a very severe slippage reaching to almost half of the stomach. So you have to intervene right away. Otherwise, if you wait 24, 48 hours, then you will have perforation and a disaster in coming. You know, the trends in USA was the same around the world, but USA started doing bands much later than Europe, and then everyone had a band. I remember that in New York Institute for Obesity,
they used to do 20, 25 bands every day, and then later complications started, and now less than 5% of bariatric surgery in US are done starting in 2015. Now probably it's less than 1% are bands. Again, I will skip this and go over. So these are the types of slippage, and anterior, posterior, and these are also several types. I will tell that in my experience, this, and this can be still managed without surgery by deflating the band and waiting and then doing, especially if the patient is not symptomatic that much. If he doesn't have any reflux, the patient is better, so you can wait, repeat the study, and then say, tell whether you have to do surgery or not. However, in these cases, you'll always have to go surgically, delayed or right away, depending on the situation. And this is a great picture about how a band can migrate inside the stomach, and this is how it looks when you remove it surgically by gastrotomy. I will not talk about all of these. However, you can remove an eroded band by gastroscopy, by specialized instruments, and however, it needs to be completely eroded. If it is partially eroded, less than 60–70%, then the only way is to remove it surgically and laparoscopically, and it is done easily. The problem is that these bands can detach sometimes, and you will find them sitting in the intestine, small intestine. So you'll have to go in, sometimes you have to resect and do enterotomy in order to remove it. Mind you, this is a picture that you see frequently, and you should never disregard it, because most of the times, in 90% of the cases, it's an erosion that has and the infection migrated around the tubing, and it's showing outside at the port, and in this case, definitely you'll have to remove the port and the whole thing. And some patients come in with sepsis in this case. Another reason for infection of the port is what I have seen in at least 5 of my patients, is that they were doing self-injection, faulty self-injection, and the infection travels upwards through the tubing or around the tubing instead of being an erosion. Again, you have to remove the band and the whole thing. Should we do it in 1 stage or 2 stages? There are cohort studies, systemic review studies around the world, and they all say that you can do it at the same setting. However, they don't say whether it is because you have a complication, erosion or slippage, and they are talking about the whole issue. So we will concentrate now on the angry looking fundus, and this is a different situation compared to the others. So we cannot depend on this issue to say that, yes, we can do it in 1 stage. I will tell you, never do it in 1 stage, or at least rarely do it in 1 stage. In the following cases, I will skip this. So erosion used to be very frequent in the early days when people used to do it perigastric. Then when they chose the pars flaccida technique, it decreased in number to less than 1%. And however, this is a very ugly looking situation that you have to manage in a difficult situation. If another bariatric, in this situation, I will repeat it again. In this situation, if another bariatric procedure is required, do not do it in the same sitting. It's contraindicated. You should not, again, you should not do it in the same sitting. Now, this is my experience, conversion from, for slip bands. I had the conversion to bariatric surgery is feasible in one stage in cases of non-slipped or mildly slipped and dilated pouch. You can do it in this case, but of course you should do it case by case. You should decide intraoperatively what to do. In moderate slippage with little inflammation and healthy fundus wall, revision can be entertained. And repositioning, this is what I used to do in the beginning when this was a very precious procedure. So I repositioned the band, even in severe slippage, to their original position. So repositioning is feasible and sometimes very difficult. Fraud with complication like perforation. And my personal choice in revisions is OMG as a first choice, laparoscopic sleeve gastrectomy second, and the third is Roux-en-Y gastric bypass. Why? Because I want to avoid the fundus in this case. If I want to do it, I want to be away from the fundus as much as I can. This is why I choose OMGB. And why OMGB, not sleeve as a first choice? Because we say that we don't replace a constrictive surgery with another constrictive surgery. However, we cannot generalize this on everyone. So I had over 300, around 300, 500 bariatric surgery. 1600 are sleeve gastrectomy, but I had experience in 1220 bands. And I had to go back in around 300 cases for revision of bands for several reasons. 15% slipped and less than 1% eroded. I repositioned 68 cases, but 2 of these had perforation and I had to come the next day and then remove the band and suture the whole thing. And 94, I had to remove them for slippage as well. And I conversed to 112, 63 were laparoscopic sleeve gastrectomy, though I advise the patient that bypass is better in these cases, but patient choice is also very important, and they come in, no, I want sleeve gastrectomy, I don't want the bypass. Lesson learned. Repositioning is feasible but frequently difficult and time-consuming with high rate of complications and rare recurrence of slippage. Those who have good weight loss usually demanded keeping the band and continued to have acceptable outcome. Erosion is converted in one stage should be to OMG in a highly selected cases. I don't advise it. Again, to avoid the fundus as much as possible. However, delayed the procedure is recommended over 3 months in order to have less adhesions and less inflammation. Later conversions are feasible in most instances despite the level of hostility at the fundus in the previous surgery. And OMG is my preferred procedure, but most patients in my community choose LSG. Stapling, suturing will be discussed later, but definitely you need to carefully select your suturing or stapling devices and the height of the device, which is very important because even it's crucial in deciding what to do. Choose the appropriate stapling height, definitely. Combined gastroscopy with laparoscopy can be of great help in these cases. You can monitor with the gastroscope during the surgery. Stapling devices with inbuilt sensors can be of help. Be prepared for surprises, since imaging can be misleading. What you see in imaging, even in CT scan, does not necessarily imply what you will see inside the surgery, so be prepared. And I still do bands in a selected group of patients who are close to follow up and who beg for the procedure despite explaining and sometimes exaggerating about the possible complications. I still do 5 or 6 cases a year, which is less than 5% of what I do. Except for its easy reversibility, when uncomplicated, bands have the highest long-term complications among the procedures with the lowest outcome. So the highest complication, long-term, and the lowest outcome. Good results could be still observed in selected group of patients with open clinic follow-up and often with yo-yo state and uneasy food habits. Do not reposition bands unless forced to do it, and it is easy. And this is our Lebanon. This is the mountain. This is the beach. So if you are, we are welcome to visit us one day. I will show a few cases. Let's run the video. Do I have time? How much? Yeah, go ahead. Let's run the video. So this is a slip band, and you can appreciate the look, a lot of inflammation. Okay, and you should always follow the tube. Follow the tube in order to reach the knuckle, and when you reach the knuckle, it becomes easier, because in this case, and I always use monopolar device in these cases. Occasionally I do the bipolar, special bipolar device. So again, you can cauterize over the band as much as you want. Of course, don't overdo it, but definitely you have to follow the band. Don't lose the band. Don't cut away. Follow it in order not to be lost in the anatomy, which is already a difficult anatomy. Can we forward it a bit, please? Yes. So now you can appreciate how ugly this fundus is. It's very ugly looking, very much inflamed. Despite all of this, whenever you remove the band or you cut the band, then the anatomy completely differs. You will have to cut the band, the fibrous band beneath the tubing, the band, because otherwise you will have problem in appreciating the anatomy. And following this, if you want to do, if you're forced to do, or you have to do another surgery, you need to have a clean, the greater curvature should be obvious for you. It doesn't, if you have a knuckle inside or it's constricted inside, leave it, go out. And if you cannot understand the anatomy, don't do anything. Go outside, and that's it. Can you go for the next one, please? Yeah, this is a case where I had a perforation in here. You can see it just underneath the band. I realized it. The plan was to do a sleeve gastrectomy. So when I removed the band, I sutured the perforation, and then this perforation was away from the stapler line. I continued, we did a sleeve gastrectomy for this patient. Can we go to the other one, please? This is a very ugly case. You can see that the fundus is stuck to the liver. And despite all of this, the patient insisted she wants to keep the band. She doesn't want to remove it. And then, okay, I said, fine, let's do it. And after a heavy dissection, difficult dissection, I inserted methylene blue. I was sure that there were nothing. The next one, please. Next one. The second day, this is what I found. And the perforation was obvious in here. So I removed the band, sutured the gastric perforation. The patient fortunately did well. However, her brother was a journalist, and you know what happened next day. Next one, please. So this is an eroded band. And when you open, definitely, if you have a partially eroded band, less than 50%, you can just remove it, cut it and remove it. You need to suture it or drain it. You don't do more than this. However, if you have a completely eroded band, then do not attempt to cut at the band. Go below the band, below the level of the band, 2 or 3 centimeters, and open the stomach in a healthy wall area. Then try to remove it, and this is what you find. Okay? What I do, I cut the band, I cut the tube, definitely cut the band in two go ahead, and then remove it. This is where I cut usually, and sometimes you have to search for it inside. So it is not that obvious that you find the band inside the stomach. You have to search, you be careful, take your time. Sometimes you have to enlarge the incision until you find it. Can you forward, please? And after careful search, you will find it and catch it. And you can see the effect of the gastric acid, of the acids in the stomach, on the color of the band. It becomes black. You can see it. Okay, go ahead. The next one, please. I think this case was my first erosion. And I was going in because the patient suddenly, she is not, this is what usually happens. Suddenly she said she was doing well, losing weight. Suddenly she had mild abdominal pain, mild epigastric pain, and then it doesn't work anymore. You inflated, deflated, it doesn't work. Then I thought that, well, because we were still young in these procedures, then we remove it and then do sleeve gastrectomy. All of a sudden, I went in, and it was a very bad-looking erosion. And I had to fiddle for 4 hours with this patient because I did not understand in the beginning what was happening. This is when I said that we need, it does not always reflect what you see on X-ray, on CT scan, does not always reflect what you see inside. Forward, please. You can make it faster, no problem. No, it doesn't matter. Okay. So I had to open. The knuckle is outside and partially outside. However, you'll be surprised inside. The next one, please. The next, that last one, keep it then. Okay. Again, I'm only using the monopolar. And all of a sudden, you'll find yourself around a structure in the, inside the stomach. Definitely, I did cut it. You should always worry about the knuckle, because if you try to pull it the wrong way, then the knuckle will stick inside the stomach and you will not be able to remove it. So have the knuckle all the time, you cut it in a way that you can catch it and remove it. And this is what I found inside. I sutured the stomach. The patient did well, fortunately, and later in 2 or 3 years, she had a bypass phonic disc procedure. Thank you.
Thank you, Professor Mustafa. Thank you. Next presentation will be Dr. Georgi Zurabashvili.
Why some bariatric surgeons have less major complications than others? Thank you.
Hello, my name is Georgi Zurabashvili. I'm working at St. Yon the Merciful Private Clinic as a general surgeon and bariatric surgeon. Today I'm going to talk about why do some bariatric surgeons has less complication than others. Honestly speaking, it's quite difficult to answer this question. There is no evidence, but there are a few factors which influences to complications. So bariatric surgery is most effective treatment of obesity and obesity-associated disease. Perioperative mortality rate is below less than 0.25%. Around 20% of bariatric patients develop a short or long-term complications. As I mentioned, there are a few factors which, there are more factors which influences surgical outcomes. Those are medical conditions, institutionals, patient selections, and surgeon factors. Bariatric surgery requires expert surgical skills and advanced clinical knowledge. Even though there are conditions which are high BMI, high ASA score, hypertension, diabetes mellitus, obstructive sleep apnea, gastroesophageal disease, esophageal reflux disease, and asthma, which increases complication rate. As well, institutional factors are quite important. As we know, bariatric surgery requires a multidisciplinary team which consists of skilled surgeon, expertise surgeon, anesthesiologists, interventional radiologists, as well as there should be psychologists, dietitians, endocrinologists. As well, institutions should follow evidence-based medicine, which are, for example, ARABs or fast track, which minimize, following those guidelines, minimize hospital stay, as well promotes quicker recovery for patient. As well, as I mentioned, it requires expert surgical skills, so a young surgeon should be trained under supervision of professors or their supervisors. Sometimes we have to offer patient right surgery and right procedure. If the patients are older or revisional procedures are planned or previous open procedures, preoperative comorbidities and high BMI, there are some another options, and it's not mandatory to do directly bariatric surgery, and you can offer some bridging procedures or obesity medical treatment as well. And most important is surgeon factors, which requires experience, continuous education, technical skills, short operative time, intraoperative decision making, and team communication. I can show you Bloom's taxonomy, which consists of several steps to become surgeon, and then you can continue education to young surgeons. As a first point, young surgeons should memorize the steps of the surgery, and then they can do some of steps in times of surgery under supervision of professors or supervisors, and after that they can continue their practice in bariatric surgery. Now I want to show you how important is standardization of the procedures. For example, we know that in times of bariatric surgery, most bariatric surgeons are doing procedures to Lloyd Davis position, and the surgeon stands between the legs, and you can see when the patient lies in the flat condition and the anti-Trendelenburg position. So view of the surgery is quite easy, and the assess of the incisura angularis, or what you want to do to the stomach, is quite well seen. As well, the trocar placement is quite important. We personally, we are doing angulated trocar insertion to have better motion and better ergonomics, to compare to just around 90 degrees of placement, and you can see the 45 degree of placement, trocar placement. As well, insufflation. There are several techniques, Hassan techniques, needle Werish techniques, and the other stuff, but as we know, our patients are obese patients. It's quite hard to assess to the abdomen, so the most appropriate way, I would like to say, is using Visiport, just visualizing where we are going, and you can see the fascia, and then after that you are inside the abdomen. And the standardization of procedure, for example, in terms of one anastomosis, gastric bypass. So we have several steps, and we have to do this: gastric pouch creation, posterior gastrostomy, location of the trace angle, counting 150 centimeter of biliopancreatic limb, anastomosing, closing Peterson space, sometimes doing anti-reflux needle at the Carbajo, according to Carbajo, and then closing skin closure. And there are several steps which are shown, and I will show you. And creation of long and narrow pouch, posterior gastrotomy. It's a founding of trace angle, making anastomosis. Personally, we and our institution is doing with the left-handed making sutures, and like a vascular surgery, we are always taking both edges from different side, from the right side and from the left side, and just crossing those Wheelock needles, and the closing, doing anti-reflux sutures. And as well, after operation, always we are trying to do leakage tests. So we are doing leakage tests, we are not using methylene blue test, just we are using gastroscopy and going through the anastomosis, making insufflation to avoid any leakage. So it doesn't covers 100%, but it at least it decreases chance of leakage, early leakage, which happens around 3-4 days, and which is the factor of the suturing problem. Thank you very much for your attention.
Thank you, Dr.
Let's
Georgi.
give some question, because we have, you had...
start now.
No, yes, we will just... could we just have 1 or 2 questions? Thank you.
Yeah.
Just, it was a really interesting presentation. Thank you very much.
You are welcome. Thank you for your listening and the interest.
As we understand, there are some recommendations from your side. Could you just underline especially what's about it, your opinion?
It's, as I mentioned, bariatric surgery is requires expert surgical skills and advanced clinical knowledge, and as well bariatric surgery requires standardization of the procedure. Not only bariatric surgery or every surgery. For example, following up enhanced recovery of bariatric, after bariatric surgery or fast track, both protocols are quite minimizer of hospital stay, and helps to patient to go at home and recovery, minimize the postoperative pain. For example, in times of thoracic insertion, we are always using local anesthetics as well. Patient positioning is counted in times of laparoscopic surgery as a second assistant, not the first, but if you are positioning right way the patient, you don't, the access to the main and target organ is quite easy. After positioning as well trocar, there are quite high complication rate of trocar in terms of trocar insertion, so we have to find best solution how to insert the trocar. We are always trying to insert trocar from the process of spinous xiphoid around 50-20 centimeter, and there is no connection between umbilicus, just measuring and placing there and avoiding the placing trocar with the straight angulation, just 45 degree. And as I mentioned, every surgeon should have their standardization procedure. For example, there are surgeons who starting doing first as a first step localization of the traits ligament, and then they are making creating pouch. But there are, so it doesn't matter. But every surgeon should have standardized procedure, and they should do every time each. And then the right to offer right surgery to patient as well.
Thank you very much. Haris,
You're welcome.
Dear Haris, do you have any question on this? One second.
Is standardization of its meaning. You have to put the position in the same time, at the same position for everybody, for every patient, because all the equipment beside you, he will know what to do. Everyone has to know exactly what to do. So you have to put the trocar in the same places, and the nurse and the staff should do the same things, and like that you will never have problem. But I have a question. You do always gastroscopy? But you don't think that it is a traumatic because if you want to do gastroscopy, you have to push the anastomosis by putting a little bit a gas.
Yeah,
you are not afraid some way.
Yeah, we never had gas-induced leakage after gastroscopy, and we had some cases. So personally, I started, as I told you, my career around 4 years, but before that I was as a young surgeon, and I'm a young surgeon now as well. I'm not counted the supervisor and senior surgeon. But when I was assisting, they started, it was 2013-14, they started using methylene blue, and the rate of the leakage after, as a test, superiority of, to compare to gastroscopy, gastroscopy had the highest superiority. Then we started gastroscopy to go through the anastomosis to make better insufflation and to avoid any missed needles as well. And as well, I want to mention sometimes with the gastroscopy you can mention sleeve stenosis as well, and the stenosis of anastomosis is a little bit smaller.
I have another things. I have another point to say. To avoid the complications, our surgeon, we have to be to know very good planes, because our operations are related to dissect planes, not only in obesity, in colon, in every surgery, laparoscopic surgery. And when we start to do laparoscopic surgery, we understood more and better planes, like traits like how Girota and the others planes. So I think for the new surgeons, they have to know exactly planes and anatomy. Anatomy is the best things to avoid the complications.
So and nowadays, laparoscopic surgery helps to find easy access to planes as well.
So I'd like to ask you a question in a different way. Your topic, of course, is very interesting, very nice. Now, can I ask you in brief, Just 5 points, 5 sentences, what you saw in surgeons, what they were doing that led to complications, intraoperative or later. Just 5 simple things you observed.
So the question is what surgeons are doing on the wrong way. Yeah. So at the first point, as senior doctor mentioned, it's knowledge of the plane.
Now tell me specifically what you saw, that in this case, surgeon did this, led to a complication. Second, did this, led to a complication. So that that would be a good sharing for everyone.
So for example, leakage from after sleeve resection, one of the most high rate is resection using linear staple a little bit closer to angle of His and making stenosis and increasing the pressure inside the, for example, not only the leakage is the one complication, for example, obstruction after bariatric surgery and after bypass, not closing the Peterson space, because Peterson space closure is getting popular, and now we know that there is a 10% of chance of getting obstruction after late or early obstruction, and the knowledge this, and as well space of mesenterial space closure as well. Sometimes it's the surgeon likes to have low pressure inside in times of surgery during operation, and we are missing small bleeding points, and we have to be aware about it. Personally, we are asking to increase blood pressure after finishing operation, and then just see where it ends. I mean, it's not 100%, you are not 100% sure, but at least you are decreasing chance of complication. As well, I would say the patient right selection, because patients are coming to you and you are offering right after surgery. And nowadays we have several steps and several options. For example, bridging
Those
procedure.
are all theoretical. I'm just asking practical.
Practical.
Like, for example, if I may add to that. For example, using high energy source on a staple line can lead to a perforation or a leak. You rightly mentioned closure of Peterson space. Many surgeons still don't do it. You should do it. Measurement of the whole small bowel. If you do a bypass and you have the bowel length is short, you're going to have malabsorption and complications. So I mean things like these.
And what about measuring? There is two approach, because sometimes it's there is quite high incidence after measuring small bowel.
So you have to, the perforation, iatrogenic perforation. So you have
Personally, I had this.
Agreed. So I've seen this also. But then you have to be careful. And when you push the bowel while measuring, when you push, it can perforate. But when you draw it from a upper source, if you draw it up, you will not then perforate. So these are the points.
And as well clockwise measuring and not anti-clockwise.
I have a comment with all respect to Professor Surendra Ogale. Personally, I measure 100 of cases, whole bowel length. It is about in our country, like in Middle East, 700, 600, 800. So maybe from 700, maybe I never measure 400 or 500. This is the reality that I did more than 2,000 cases. So yes, I measure about 500, 600 cases. Then no need, because as mentioned, so if you will go, there is chance of iatrogenic injury to small bowel. So how can I just take a risk? Just imagine patient with BMI 60 with thick mesentery, and you are going to measure whole bowel length. Then if you need to go, must change the position of the patient. Patient must be supine or head down, tilt to left side. You must be at the left side of the patient, add a trocar in left lower quadrant. Then you must start from ileocecal.
That's one point.
Sir.
So the shortest I've seen is 340 centimeters. There are some 450 centimeters. And if surgeons can do complicated surgeries like liver transplants and everything else, you mean to say they can't learn to measure a bowel safely? I can't believe that. So therefore, my argument for measurement.
Again, the issue of combining gastroscopy with laparoscopy is being practiced in many places. And in fact, it offers a lot of safety and accuracy. And even if you inflate a bit and then you have a leak, then it means that your sutures are not that good. So you can even inflate in order to find, you put some water, if you have bubbles, then definitely you can check for it. So it's a great practice. The problem is it increases the cost, and you should be afraid about your scope all the time, because in some cases they injured or they caught the scope inside the suture line. Concerning measuring, definitely is a hassle to measure every patient, and it takes some time. But the question is, if you find 9 meters or 10 meters small intestine, and you're planning to do an OMG, does it change anything for you? Okay, so again, however, definitely in the rare cases where you have 3.5 meters, which is very, very rare, it's unlikely that you see. You will see it right away. If you open up, you will see that you have very little intestine in your, and then you might decide to go and measure. If you are going for a duodenal switch, definitely you should measure. Definitely, but you measure from the cecum upwards and not from the ligament of Trice downwards. Thank you.
And you need changing position as well, and trocar addition, and you have to go to the left side. Yeah.
I'm so proud that we have such a young sir, and who is so professionally explaining this, and really happy that we have such a star doctor, Georgi. Thank you. Thank you very much. You are just really excellent. Thank you. Now we have debates, and I would love to introduce Nino Gabidzashvili, who is our star doctor endocrinologist. And I would love also to give place here Professor Imran Abbas, please, and Surendra, please, to have the debates about this is in the era of medical and endoscopic treatment for severe obesity, complex revisional bariatric surgery. Options like SADI and BPD, DS will become less relevant. This is about the debates. We have 12 minutes. Please take place. I'm really happy to give the place to you. Thank you. Thank you. Professor Koba, it's your place as well.
Yeah, Dr. Koba. So let us start the debate then. We have Dr. Nino Gabidzashvili talking for the proposition. So let's hear what you have to say, and then what Dr. Imran has to refute.
When I was preparing for the debates, I really was thinking that really I don't think that there is some controversy between different methods of obesity treatment. I rather think that there is a very big diversity, very big choice today, and the proper choice should be made for the patient. But still, as an endocrinologist, I will start with medical treatment advocating. So, treatment options for obesity include energy deficit diets, behavioral therapy, exercise, anti-obesity drugs, minimally invasive endoscopic techniques, and laparoscopic surgical treatment. Choice of the treatment depends on BMI, presence of obesity-related comorbidities, patient preferences, and financial issues. In recent years, the landscape of obesity management has shifted dramatically with the introduction of new treatments. Traditional bariatric surgeries like single anastomosis duodenal bypass, SADI, and biliopancreatic diversion with duodenal switch have long been considered effective options for patients struggling with severe obesity. However, advancements in both medication and endoscopic procedures are challenging their dominance. Medications like GLP-1 receptor agonists, tirzepatide, and minimally invasive endoscopic techniques, such as endoscopic sleeve gastroplasty, have gained attention for their ability to offer significant weight loss with fewer risks, quicker recovery, and less ongoing commitment. This raises an important question. How do these newer, less invasive treatments compare to the more complex surgical options like SADI and BPDDS? So let's explore how each approach stands up against the other, considering factors like effectiveness, risk, recovery, and patient preference. Medications like GLP-1 receptor agonists, semaglutide, the most popular, and tirzepatide, are transforming the way we manage obesity. These medications work by mimicking the action of a hormone in the body that regulates hunger and blood sugar levels. Patients taking these medications often experience substantial weight loss, up to 15–20% of their total body weight, without undergoing surgery. The beauty of medications is that they are non-invasive, don't require recovery time, and can be stopped or switched if there are side effects. Moreover, these drugs also help with obesity-related comorbidities, such as type 2 diabetes and hypertension, making them appealing to a wider range of patients. Medications are also easier for patients to adhere to because they typically require only periodic injections or daily pills, as opposed to the lifelong commitment to supplements and frequent follow-ups required by surgical options.
Thank you, doctor. So regarding, if we will see, excellent presentation. And if we see now the role of GLP-1 analogs, that is the reality, and we must respect. We are a scientist. I am practicing in Dubai, and you can't believe our initial bariatric surgery is now less than 50%. So now Monjaro is available, and also third generation in loop. So we are realistic, and endoscopic access, as well as if we see, yes, we can do this pouch reduction and also gastrojejunostomy, size reduction, everything I accept. So what is my question? So if a patient after weight regain, after sleeve gastrectomy or Roux-en-Y gastric bypass, and you are treating only with medicine, just imagine patient after such an aggressive surgery, such an aggressive surgical intervention, again gain the weight. So you can treat it permanently? No. So also as a surgeon, I cannot ask when I will go and I will do a revisional bariatric surgery and that will be a permanent way of treatment. Also I cannot ask, because personally, now Surendra is here, you know better than me. So this is multifactorial disease. Obesity is multifactorial disease, and when we deal with such a multifactorial, we cannot ask only one way. Yes, this is the teamwork, MDT, multidisciplinary team. We must play with the patient healthy lifestyle. But again, if as a realistic, that my experience about 2 decades in bariatric surgery, I can ask again revisional bariatric, proper revisional bariatric surgery will stay on the top.
Yes.
Good. So we heard your arguments for. That means you are saying that SADI and BPD-DS will become less relevant, will not be required.
I don't think so, really.
That is
I
what
think
you
that
are
they
talking. That is your topic.
That I'm talking about. But still, I think that bariatric surgery, even large and revisional ones, will have their place in the treatment of the patient. Severe obesity, BMI more than 50, maybe the site of their application. More modest obesity can be managed by drugs and by endoscopic procedures as well.
The topic is severe obesity.
Yeah, but
We talk of severe obesity. SADI and BPD-DS will become relevant, then you are helping him. You
the
have
main
to say
idea
irrelevant.
is that my own position, I was asked to participate in these debates. Of course, I am advocating medical treatment, and this is what I use in my everyday practice and have very good results with our patients. But what I see, the main thing is that the doctor cannot be addicted to one kind of treatment. The doctor should really understand the patient's situation and adjust the best treatment.
We are saying less relevant. Now, Dr. Imran is against it. He's saying, in spite of medicines and endoscopic treatment, SADI and BPD-DS will still remain.
Sir, of course, and
It will remain either in in less severe obesity, for example.
No, just because our topic
this is
is
only severe obesity.
Our topic
is severe obesity.
Severe obesity, and because now if we see in Dubai, because we have easy access, our patient have easy access to any type of GLP-1 analogs, and Dubai was one of the first city when we received Mounjaro. After US, Dubai was the first city we received Mounjaro. And now more than 1 year our patients are using, and yes, effective. But now what is happening? What is the reality? Who can use long time this medication? Now our patients are consulting us with weight regain after weight loss using of GLP analogs. And I also talked with someone like Scottish Kura and many of them. So what will we do now? Because this is not initial bariatric surgery. A patient with initial bariatric surgery, we have different protocol. Patient after weight regain as a revisional bariatric surgery, a different protocol. How I deal with the patient who used Mounjaro for 1 year, lost sufficient weight, and now come back with weight regain. This patient will be not initial surgery. So we need a protocol. Haris is also listening me, and we need, and hope Haris will arrange such a webinar in future on the platform of IBC. What is the new protocol for the patient? How can we deal with patient weight regain after GLP-1 analogs? And my experience and comment is this: yes, surgical intervention, especially in this super obesity, will remain on the top.
May I say an argument? So I think that what we see in our everyday practice is unreal expectations of the patient, not only in regard of surgeries, but also in regard of medical treatment. I want to emphasize that obesity is a chronic disease. And as every chronic disease, it needs chronic treatment. And behavioral therapy should be lifelong. And this the patient should understand with medical therapies and with surgery both. Because we see patients with weight regains after surgery as well, and we see them in even worse situations when they have weight regain plus vitamin deficiencies and complications, which our colleague was talking about, and one of the patients was our patient from the shown there. So I think the proper expectations that it's a multifaceted approach should be used, that teamwork is needed, that every kind of treatment, is it medical therapy or is it surgery, needs behavioral changes, psychological support, dietary modifications lifelong. exercise is lifelong. Without it, nor the medical therapy and nor the surgery will be effective.
So, Dr.
And both
Nino,
will have weight regain.
let me ask you this. So, when you have a patient of severe obesity and has lost weight and now there is weight regain, so are you able to maintain them with medical and or endoscopic treatment, or do you find any patients going for surgery in spite of your treatment?
The approach which we use, of course, we always, I think not only we, but all the doctors try to start less risky therapy. If our patients do not respond effectively or have only temporary effect on medical treatment and then they regain weight, of course, we ourselves advise them bariatric
So you do
surgery.
find them going for surgery?
Of course.
So then you are losing the debate?
No, I don't
That-
think. I never thought for this debate, so I don't look as for therapy and surgery to be opposing each other. I
Agreed.
think we are more complementing each other. Yeah, we are multidisciplinary team. And even when Manana
So what percentage of
invited
your
me,
patients
I said
will
it
go for
initially.
surgery? In spite of your treatment, what percentage of your
myself said
patients?
it for surgery. I myself
How many?
indicate surgery.
What percentage?
What percentage? I can't say the exact number because we don't have statistics.
Okay, Dr. Imran, then I'd like to ask you, when you have patients with the weight regain and then earlier would come to you for revisional surgery, now what percentage do you find that don't come for revisional surgery because of the medicines and endoscopic treatment?
Sir, this is a good question, and now because I am in a center that is a tertiary hospital and we have all types of facilities, I must be realistic. So nowadays about 70 to 80% patient prefer to go for medication and also endoscopic treatment because we have a good endoscopic interventional endoscopist in Dubai. But what is the next question? They are satisfied? No, unfortunately. First they try, they go, and again after 1 year, after 1.5 years, again they back to my clinic.
So the advantage of medicine and endoscopy is it can be repeated.
Yeah.
The problem with that is the cost factors for the patient. So if you have a government system which is paying for any and all treatments, would you expect that majority of them will then continue doing the medicine or doing endoscopic procedures also repeatedly?
Sir, this is a good question because in Dubai we have two types of population. Local population completely covered with government and they do these things. They use Monjaro, they go for, because completely free, no payment. But when we will see, so those people who are just resident and so they discuss with us, if I will go for Monjaro, so how much it will be expense, they discuss because MDT we have endocrinologist. Some of them they go, okay, I will check and I will see, but they are completely oriented. But most of them, again, when they see the expense of this medicine.
So can we say that if the cost factor is removed, the patients will stay with medicine, recurrent treatment, recurrent endoscopic treatment, and when the cost factor is involved, then they will try that maybe initially, and when there's weight regain, and if there isn't enough success, then they will come for surgery. Would that be a fair
Yeah, this is the
point?
reality. This is reality, and patient don't like to go for surgery. So this is the reality. Till they are not interested now to go for endoscopy because they don't like any type of intervention. When they see, okay, I will just take Monjaro or such a medicine and I can lose the weight.
What about combination of endoscopic treatment and Monjaro? Don't you think it has a synergistic effect and that might again keep them away from surgery?
Sir, personally, I have no such experience or any data for my patients, but apparently it's looked good. So you will go, you will do a little intervention, you will resize the pouch, you will increase restriction, and also when you will also support the patient with the GLP-1 analogs must be effective as compared to if you will go only one type of treatment. But personally, I have no such a data.
Thank you very much for your very interesting discussion, but I want to remember all of you about new standards from IPSO. That is that when a patient has more than 35 BMIs, we have to suggest them the bariatric surgery. We have to suggest, not we have to do it. We have to suggest. That's very interesting, and I agree with Dr. Nino that endocrinologists, psychologists, we are working together every time. But it's not important, this is regain or without regain. If patients has a BMI more than 35, we have to suggest bariatric surgery, and patients will be choose, they will do surgery or not.
So Dr. Koba, I might then here add that a physician would be suggesting the medicines, and only when they are forced to or the patient forces them, they'll say, okay, you could go for surgery. And we as surgeons will be suggesting surgery most times. But the reality is 98% of the patients don't come for surgery. They are sitting at home. So that is why they're coming out of the woodwork, and now they are meeting the physicians for the first time to try to get rid of their obesity. And only the 1% or 2% come to us for surgery. So yes, Dr. Nino.
Can I add something? I absolutely agree with Dr. Koba, but will add that we should suggest bariatric surgery to the patient with BMI 35 plus obesity-related comorbidity, and over 40 even without comorbidity. This should be, of course, considered. The main thing is that a patient going to surgery should have proper expectations. The idea is that most of the patients think that the surgery is like a magic thing which will solve their problem without any lifestyle modification, without any lifelong vitamin supplements. And after getting the real information, they might not want it. So I think it's we should suggest, but it's the patient himself should decide what he's, because...
But Dr. Nino, as I said, 98% don't want surgery. So when you find that, as Dr. Koba said, if the BMI is more than 35 with comorbidities or BMI more than 40, how do you then convince them, you as a physician, convince them for surgery?
What I'm doing in this case as a physician, first of course, every patient, every human wants the less invasive approach. I think this is very human, this is very normal, right? Of course, we try to treat our patients with medical therapies. If they have good result, and we try to use school for obesity, school for diabetes, to motivate them for lifestyle, to make psychological support, this multidisciplinary team. If they still don't have result or have temporary result, then we suggest them surgery. But of course, we try with less risky and less invasive treatment. We start with it.
But how do you...
In case of failure, we advise them.
How do you ensure that they go for surgery? Because you suggest yes,
we can't ensure
but majority of them don't go.
No one can ensure it. It's patient's decision. But my main idea as a doctor is, would it be medical therapy or would it be surgery? The patient should be properly informed and have realistic expectations. What I see as my role as a physician. But I think that, of course, you are absolutely right that in most of the countries, the coverage system, finances are different. And very much decision of patients and healthcare providers will be very much dictated by the financial issues as well.
Thank you very much. Dr. Nino, sorry. 3 men for 1 woman against. It's not normal, but this is a medical discussion. But I want to finish. Sorry.
Would Dr. Harris, would you like to ask something to our 2 debaters?
Thank
Haris, this is a definite good question. So if we see, we have a multiple, definite in this debate, they highlight SADS and BPD, and as you mentioned, these hypoabsorptive surgeries and very strong and need a proper follow-up, no doubt. But as a surgeon, we have different options. So maybe personally, I will not go for such a surgery, because especially that I am doing a surgery in those areas, maybe patient will go and will not proper follow. But because in this debate they mention, and when we compare with, just imagine a patient can follow, or we select the patient, and also we can follow, and patient can take supplements, and we can follow till 10 years. Such a patient, so imagine such a situation, then definite I will go for SADS or BPT, that is more effective as compared to endoscopic and pharmacotherapy.
Dear colleagues, I don't want to end this debate without saying my kind hello and
Dr.
my
Nino.
gratitude and thank you to Dr. Gumps, who was the one who helped us to make this multidisciplinary team. And in regard to him, we have a school for obesity patients today, and have this pre-surgical consults, information of the patients, and very planned pre- and post-surgical medical interventions. Not surgical, of course, but medical team. He helped us very much to organize the process, and I want to say thank you to him.
Yeah, Dr. Nino.
Hello, Dr. Gams. Hi. Glad to see you.
Now he's just presenting. Yes.
So, Dr. Nino.
Andrew, we miss you here. Thank you.
So, as So to sum this up, I think Harris raised some relevant points as far as the specific operations that were mentioned here, the SADI and the BPD-DS. It is a reality that in the world, the incidence of BPD-DS being done is less than 1%. SADI is a little more, and it of course got approved by the organizations. But if you look at it in this manner, that majority of the surgeons are afraid of doing dissection in the duodenal area. So any surgery involving the duodenum, the artery over there, and anastomosis, etc., there are very few surgeons who like to do it. In skilled units, yes, it is really good. The next issue is operations very effective. Like in India, in our setting, operations very effective, but nutritional issues are so many that it's not used as a primary procedure for sure. Revisional sometimes. So, and of course, with the advent of the obesity management medication and the newer and newer evolving experience with endoscopic procedures, I think there is going to be a combination of all this to take care of patients. But of course, patients want pharma first, maybe, least invasive, so endoscopic, and the last is for surgery. So thank you very much to our debaters. Thank you, Harris, and welcome to our session, Dr. Andrew Gums.
I'm proudly introducing Professor Gums. Now he will present a next presentation for us, and it's really impressive, because I think that this time when we have smart and smart staplers, compressing intelligence, artificial intelligence, all of these together. I would love that Professor was introducing about next chapter, how smart are smart staplers compressing intelligence to a higher level. Okay, please.
the future that I envision. I remember when I was flying back from Houston a few years ago, Houston to New York, and the landing was very rough, it was very hard when we hit the tarmac. And the pilot got on and said, sorry everybody, but we used auto land to land the plane. And I didn't know what auto land was, so I looked it up, and it turns out auto land is an artificial intelligence that is used to land planes. So I thought to myself, we're always worried about consent and ethics. Is it right to use artificial intelligence in the time of the operation? And as you can see, industry passed this through without even asking any of the passengers our opinion.
Thank you very much. I have one question, Professor. About the staplers, what we use in laparoscope and what robotic surgery. Could you just give us idea what is different, or there are any difference, or what about the smartness about this side?
Well, yeah, it's interesting because I work at a center in Paris. It's actually the busiest bariatric center in France. They do here we do over 400 bariatric surgeries a year. And really over the last year or so, it's transitioned from laparoscopic to robotic with Da Vinci. And actually what we've noticed as of now is more bleeding at the staple line, more anastomotic leaks at the staple line. And, as you're asking me this question, Manala, technically I have to confirm, but my assumption is that the robotic staplers do not have sensors. I think they're just automatic, they're not autonomous. So I think that the best stapler on the market right now really is the Medtronic one. I have to confirm. If anyone knows any different, let me know. But we definitely notice, not many more bleeding problems, more anastomotic leaks, and intellectually that tells me that there's probably no sensor, when the robotic stapler is actually being used. And maybe the fact that it's not in your hand, that you can't feel anything, maybe that's also a problem. Maybe that is a limitation. That's why it may be better to be at the bedside, have the stapler attached to a robotic arm while you're using it so you can feel it.
Thank you very much. One more question, please.
So, Professor Andrew, this is Surendra Ugale. Incidentally, I thought you're going to be here and we are supposed to do a session here, but we can do it with you being there. So the question to you is, when you do a sleeve, are you at present using any smart stapling methods? And are you using any artificial intelligence when you do sleeves at the current time?
Yeah, so I use artificial intelligence. I use a ligashore, and I use the Medtronic, the Signius stapler, so that also uses artificial intelligence. I like to oversew the staple line. I just feel more comfortable doing that because I oversew when I do my local procedures. I oversew staple lines and when I do colorectal. But so I consider myself using artificial intelligence. Based on the definitions that we talked about during the presentation.
So, if I may say so, I think the perception among surgeons is that ligature is one of the established things. There's nothing so special about it, is what they think. And the Signia also, for those who use Medtronic, it's a usual thing. So, what people are looking for, is there something even more special which can actually guide you as to which cartridge to use? And when you mentioned you use suturing to ensure the staple line is secure, isn't artificial intelligence helping you to know whether this staple line is secure or not secure? Should you use something, or there's no need to use something?
So, I think there's still a misconception of what artificial intelligence is. Artificial intelligence is based on machine learning, which uses algorithms, right? Uses formulas. So again, I repeat, the formulas that are being used that are deciding when you can cut a vessel or not cut a vessel, that's an example of machine learning. So that's an example of artificial intelligence. We didn't realize that it was, but it is questions about which patient should undergo surgery, which patient should get endoscopy, which patient should stay on medication. So that is something that we decided either
I
before
would
the
like some
operation
signature about this in my also explanation.
using a deep learning architecture. As far as visualization during surgery, one of the best things to do is not just from computer vision, but probably using a mixture of computer vision with ICG so that we can see where there's a problem with ischemia. Most of the problems in bariatric surgery occur because the surgeon can't see whether there's a zone of ischemia at a stable arm, at an anastomosis. So in the future, we're going to have systems that you can attach either through your laparoscope or through the laparoscope of the Da Vinci. Remember, Da Vinci is just using a laparoscope. You can call it robotic if you want, but it's just using a laparoscope. And the analysis of the image is going to use a deep learning algorithm to interpret what is being seen on a pixel level, and it'll be able to tell you where you're going to have a leak, where you're going to have a problem, whether you need to do another resection, a further resection. So there are people who start to use ICG and deep learning algorithms, using the concept of computer vision, but that's mainly being done in pancreatic surgery to look for ischemia at the cut pancreas, but also it's being used in gastric surgery, gastric cancer, and colorectal. But you could also use these techniques in bariatric surgery. I think it's going to be very powerful to reduce the risk of complications in bariatric surgery.
That's great insight into all these points. Now, I'd like to ask all the doctors present here, is there anyone here using smart stapling, artificial intelligence, AI, optic? Yes, please use the mic.
We use Medtronic Signia tri-step system, and I and my colleagues from my team is very satisfied. It's very safety, I think, very comfortable, and suggest you.
Is there anybody else over here using smart stapling? Yes, please, if you would like to answer.
I was just going to say, I've been in the American hospital quite a few times, and one of the requirements I had was that there was an electronic Signia stapler available. I was very happy when Koba had already purchased it and already made it part of the department. That was a very good sign to me. I was very happy to see that.
I have to make one remark because as you see in our audience, there are not many surgeons who can use this because of price. I think that now we are facing new era that we can do some changes about this because there are some new modern technologies which has also artificial intelligence, and there are not monopoly of the COVIDian because there is just really difficult to do any operations with artificial intelligence with so high price. That's why I'm just proud also here to have some debates about this side that we can have and we must have some different choices which in market allows all surgeons to use this artificial intelligence. And here I think the best opportunity also this regarding of our sponsors, for example, I just only want to mention X and Y, which is allowing even half in price to give all of surgeons to have and use this artificial intelligence as a stapler, as a ligature, like all these energy devices. So thank you very much for this section, and I have to tell,
It was just a question whether we are using or not, and of course, so it depends on price. We are using Ligasure, we are using Sonicision as well, and Medtronic Signia. And the main limitation is the price because it's not covered from Georgia, but I think Medtronic has special price in Georgia to compare to European countries. And as well, using Signia sometimes has limitation in terms of revisional surgery if the staple lines are covered with the clips. We are not able to cut, and it stops, and it makes as well, it stops by itself, and maybe sometimes the staplers are damaged, and that one is one of the main limitations which we are facing quite often in terms of revisional surgery.
Is ICG being used routinely by surgeons here in Georgia? ICG, as Professor Gums suggested?
So we started now, just new, and it's of course it's a limitation of cost as well, and cost efficacy.
Sir,
and it's new one for me personally as a doctor.
One comment regarding this. So as you mentioned, Signia definite is a little expensive, and always we are searching good quality with AI and cost effective. And in my opinion, XNY is now going to replace the position. Personally, I am using in Dubai as well, and it's good. And in future, as Manana mentioned, we can see more and more products in the field, but cost effective.
Yeah, because all of us, we need all of, for our patient safety and for us as well, because we are working like, I don't know, slaves now as surgeons, because there is just very less income, and because good sleep, we are using high-cost devices, and now it's the era to begin sleep well and have also good pocket money. So means that I'm not telling this badly, but that everyone have to have satisfied life, and most important for all of us is patient safety. Thank you very much. Now I'm calling you.
Can I have one question about the Manana? Can I have one question about? So one of the main usage and advantages of Signia is angulation. To compare to JJ, it's not possible to angulate well, and you have to press. And in market, I don't know.
But that's a mechanical function, isn't it? We're looking for the artificial or the smart functions in these.
Yeah, but inside the Signia, you can angulate with the finger, and to compare to other smart staplers, you cannot angulate, and you need another hand or like something, and you can control with one hand as well. And if the producers will produce Signia type smart staplers, it would be nice as well, not only the price.
Oh, so here we have some.
Hassan is here. We will ask Hassan to make
some small videos during their lunch, because now we have half an hour lunch. Kindly invited in the atrium, please. Thank you very much for attendance.
Well done, Manana. Manana, excellent. Good. Nice to meet. Well done.
მოდიში 1 2 3 1 2 შეშინი რამე ის ხო არ მოყვება 1 2 3 1 2 3 აა 1 2 3 1 2 3 1 2 1 2 1 2 3 ჰეი 1 2 3
რომ დავუბრუნდეთ თუ შეიძლება საკონფერენციო დარბაზში. ნენე რომ დავუბრუნდეთ მეგობრებო, დავუბრუნდეთ სამუშაო გარემოს, გავაგზავნოთ შეხვედრა. ვანჩი კარგია, მაგრამ თუ შეიძლება რომ დავუბრუნდეთ. კონფერენცია განახდება 5 წუთში.
ერთი ორი სამი. 1 2 3. ჰეი, 1 2 3. ერთი ორი. თემო. ამას აუწიეთ ცოტა რა. მე-4 იქნება, ან მე-5. მე-4, ან მე-5. 1 2. აუწია კიდე? კაი, იმითად დინამიკს აუწიეთ თვითონ ცოტა. დინამიკს აუწიეთ ცოტა. დინამიკს. 1 2 3. 1 2 3. 1 2 3. 1 2 3. 1 2 3. 1 2 3.
Excuse me, lunch is over.
ლანჩი დასრულდაო, თუ შეიძლება რომ დავბრუნდეთ, თხოვნაა. ორგანიზატორებისგან გველოდებიან Zoom-ში. გადასარჩენია ბარიატრია, დავბრუნდეთ თუ შეიძლება.
Hello. The lunch is over.
Hello. მეგობრებო, გთხოვთ დაუბრუნდეთ კონფერენცია, გავაგრძელოთ. მეგობრებო, ვიღაცას საერთოდ საბანკო ბარათი, ასე რომ აქ იმყოფება ჩვენთან და შეგიძლიათ მოვჯანდეთ წაიღოთ. ვერ გამოვაცხადებ კიდეც რო ეწეროს. არა, საპენსიო არ აწერია. გვარი არ უნდა ეწეროს ბარათს ისე? პენსიონერია თუ რა მნიშვნელობა? არ აწერია, მართლა. თქვენი პოვეთ? 400 ლარი.
Let's go back to the meeting room, please.
არა, ახლა
We're starting. You have now the expert discussion with you. No, another we have to expert discussion. My role is
Sir, thank you.
يا عرصة. يلا يا منيك. Dr. Harris, we are starting in 1 minute.
Excellent. Thank you.
Okay. His voice is not going up. This one is speaking, no voice. He's speaking? Yes, yes. 5, 3. أعطيني اللي هي لك إياه هون. وين صرنا نحن؟ So we will start now with the expert discussion session, intraoperative surgical decision making. The topic is related to staple height cartridge selection and sleeve gastrectomy. The chairpersons are Professor Surendra and Professor Andrew. على العلقة الشرموطة انفخوه 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 مرق ولد طيب عادي يا طيبة دكتور نبيل قاعدة وراك واحدة كتير طيوبة قاعدة وراك واحدة كتير طيوبة
That's fine.
Yes, Professor.
Gamar Joba. Again, good afternoon, everyone. I hope everyone's had a good lunch and is happy and satisfied. And we will do a short session of the symposium or the discussion we were planning before lunch. Professor Andrew Gums is not with us now because he's finished his talk, and so we will modify it a bit, and let's start this discussion on staple height cartridge selection in sleeve gastrectomy. So on the panel we have a very experienced group of surgeons, and if Manana would like to join, and I'm going to start by asking you some questions, and if you keep a few mics with you, let's have your answers. Please keep it short and brief so we can move on with some good information sharing. So, Professor Mustafa, do you have a particular method of selecting staple heights for sleeve gastrectomy cartridges?
Well, definitely this is a very important issue. And I remember the times where we used to force with strength our stapler through the stomach and getting bleeding first, and then we realized that we have perforated the mucosa. So surely we go like everyone else with the highest height, black or green at the fundus, and then we go slowly upwards.
No, you mean antrum first?
Antrum, sorry.
So,
at the antrum.
so do you do antral resecting sleeve or antral sparing sleeve?
No, I do. I go 2 centimeter away from the
pylorus.
Pylorus.
So you're
and
resecting
then,
the antrum.
Yeah, I'm resecting part of the antrum, and I use either black or green in this area.
So does anybody else also resect antrum? Just say yes or no. Yeah. Antrum, you resect antrum? No? Yes? Yes? Everybody resects the antrum. Okay. So
all of us try to begin line resection near the
pylorus.
Yes, of course.
Very good.
To maximum 3 centimeters.
Because otherwise, certain surgical groups leave about 4 to 6 centimeters, and then there are issues with weight regain we find. So once you're at the antrum, then it matters your staple height selection. So black or
yeah, black. Then if you are experienced, you will feel what's next. You will know from the first stapler, you will know what next to do, because if you still have acceptable resistance in the first firing, then I would choose the same height for the second hiring.
So do you use a motorized stapler or manual stapler?
I'm still using manual stapler.
Because the reason I'm asking is because in manual you're more likely to experience the resistance if there is, while in a motorized you may not experience it. It may just go through.
Sure, and then the usual is black, possibly green, or then you go to violet, and occasionally yellow. So these are our gold. So these are.
So you don't go to blue at all on the sleeve?
I'm not using blue at all now.
So do you find extra bleeding?
Well, sometimes, but not extra.
Okay.
Sometimes. What I usually do is I keep the stapler for 30 seconds to 45 seconds,
30 seconds,
following
okay.
the firing before removing it. And I found that this is a good method, at least to stop bleeding. Then definitely I deflate the abdomen for a few seconds and then recheck. So a lot of this, but if I apply the stapler for 30 to 45 seconds, following the cutting, then I have less chance of finding bleeding.
Professor Koba, what stapler heights, how do you choose, and what do you use for the complete sleeve transaction?
Yes, it's a black, it's a beginning of the stapling. I use black or purple, and it's dependent on the BMI. If BMI is high, of course, we start the black stapler, and if it's low.
But do you find it
45?
correlates with the BMI, the stomach thickness? It may not.
Stomach techniques depends on the
No?
tissues, tissues.
Okay, and
Thicker, yes.
the
Yes,
thickness. And
yes.
when you use purple, since you're starting at the antrum, do you find sometimes there's a splitting of the serosa? Do you find that?
No.
No.
Never. No.
Okay.
And after we change it, if you will start black cartridges, outer will be purple and outer yellow.
Okay.
Yes.
And you end with yellow?
Yes. And with
Oh,
yellow.
so this is surprising to me. Let us hear what Dr. Imran has to say.
Yeah,
Professor
sir,
Imran.
this is, in my opinion, a good debate because staple height, especially for youngsters, they must know. So we can see in male patient, the antrum is little thick as compared to female patient. And again, of course, in revisional surgery, we will face more thickness. So selection of staple height is very important. If you will do antrum with blue, there is more chance of leakage. So if you will go fundus with black, so there will be bleeding. So due to this, we must select proper thick tissue. We can start with green, we can start with purple, we can start with black. There is no issue. And also then when we will go ahead, so in the part of body, we must be with gold, or it depends again, female patient, male patient, so you can use blue as well, and routinely I prefer body until onward, so blue a better and good hemostasis. This is routinely my routine practice.
Okay. Professor, I'm sorry I didn't get... Dr. Kaha, yes. Please, Professor. Yeah, yeah, for sleeves, how do you choose your cartridges and...
First cartridge, only black.
Okay.
Only black. The second two cartridge, black, only green. Okay. It is BMI patient. It is only step lines finish green.
Oh, you finish with the green?
Yes. No.
Okay.
Only this is 80 con step length. Okay.
Okay.
My operation finish 2 step lines. We lock.
You do suturing?
Yes, sutures.
Okay.
Yes.
So if you do
I don't have. I
suturing,
don't
it
have
doesn't
like
matter.
Polo 6 წელია მე ლინკი არ ქონია და სიზდენ 6 years I don't have like I don't bleed. Okay.
Very good. So I guess if you're going to do suturing, oversewing the staple line, it
Yes.
doesn't matter what you use because you're going to suture everything.
Of course.
So that also is very good.
Bypass only pink. I have signia
signia apparat и anastomosis only medium vascular.
Okay.
Medium vascular. 3 only 4-5 centimeter.
Professor Mamuka, what do you do?
Thank you. I speak in Georgian because ყველა ქირურგს აქვს თავისი გამოცდილება და თავისი შესაძლებლობები. მე ასე მგონია. ჩვენ აქ შეკრებილები ვართ არა მარტო ბარიატრიული ქირურგები.
გადაგითარგმნით თუ გინდა.
არა, არის ეგ. არამედ სხვადასხვა ონკოქირურგების, ანუ ხშირად გვიჭავს ძალიან ეს საკერე აპარატების გამოყენება. ნუ რაც შეეხება ბარიატრიას და პირადად ჩვენ გამოცდილებას, მე შავ კარტრიჯს არ ვხმარობ, ვხმარობ მხოლოდ ვამთავრებთ ყოველ შემთხვევაში ლურჯი კარტრიჯებით, ბოლო 2 დადება იქნება ყოველთვის ლურჯით და ვიწყებთ ყვითელი კარტრიჯით. ანუ ჩვენ ეს გამოცდილი გვაქვს და არასდროს არ უღალატია და მე არც თვითონ უნდა ქირურგმა შეაფასოს ქსოვილის სისქე, როგორ უნდა გამოცდილებას აქვს ძალიან დიდი მნიშვნელობა. ამდენად რატო ხმარობ ამას და რატო არ ხმარობ ამას, ეს მე ასე მგონია რომ არც უნდა დააძალო და არც ჩვენი უნდა ვთქვათ რომ მე ასე ვაკეთებ, მოგწონს გაიზიარებ, არ გაიზიარებ და შენს კარგად იყავი და ჩანცო. როგორც არის ნათქვამი. ასე რომ we finished sleeve gastrectomy on the blue cartridge and begin to yellow. Okay?
Okay. Yep, that's good. And next?
So personally, we are using black cartridge as well with the 15 centimeter trocar in times of sleeve, because we are trying to start sleeve resection as close as possible to the pylorus. We started to use then to continue with the purple ones, and at the top, the side of the fundus, we used to use gold one, but nowadays we are using just in terms of sleeve black and purple ones. What about bypass? In terms of bypass, we are using gold ones with the horizontal section and the longitudinal section as well. And anastomosis we are making. So personally, our institution uses Medtronic, the gold standard, so it means medium thick. In terms of bypass and in terms of sleeve, we are starting with the thicker one, and then with the ABT and.
Okay, so I'll tell you what we do in our practice. We use the Ethicon green at the antrum. And it's very rare to see fracturing of the serosa with that. So the green usually does fine. Then after that we may use a gold, and then all are blues after that. Now if I've used a purple, Medtronic purple at the antrum, sometimes we have got a serosal fracture. So then we have to oversew that area. Now I want to share the experience of Professor Kelvin Higa. Those in the surgical fraternity know, one of the most experienced, very senior and a very, very respected surgeon from California in USA. So Kelvin Higa was doing earlier, his main operation was the bypass, Roux-en-Y gastric bypass. Now, after so many years, he has switched to the sleeve being the main operation, because as we all have discussed and realized, obesity is a chronic disease. So Kelvin Higa says, no matter what operation you do, after some years, they come back. So if you do a sleeve, then you have an opportunity to do something and modify it later, which is easier than when you have a Roux-en-Y gastric bypass and weight regain. Now what Kelvin Higa is doing, which was very surprising to all of us in the world, he is using only white cartridges for a sleeve. Only white. So he's getting good, compression. He has no bleeding because there's very good compression, but we were surprised that how can the white be valid, but an experienced surgeon like him is doing it. He hasn't reported problems and he is very honest with all of us. So this was a very big surprise for us. Yes.
Yeah,
Indra.
it's interesting, Professor Surendra. We were in, I remember Turkey, and in a debate, Professor Bruno Deleman was there, and Dr. Nasser Sakran present a presentation, a complete sleeve with white stapler, and also he mentioned, we have discussed with Professor Bruno Deleman, professor was sitting there in his space, and I remember Haris was also there in the same debate. As I remember, we were sitting in the same hall, and it was also surprising for all of us. But Bruno partially accept this. Yes, we can go body ahead, or at least fundus to ahead, not complete antrum. But okay, because when Professor Higa and such a great surgeon he is doing, and we can see the good sealing, and we can see there is no bleeding, because what is the main issue in sleep nowadays is the bleeding. Yes, a leak less as compared to 2 decades before, because now technology is advanced and we have good staplers. I remember earlier in 2005-06 were a lot of leaks, but as compared to that era now we are much, but still bleeding. But it's debatable, and of course, but at this stage personally I cannot start with white stapler. I cannot, because
Let me ask Professor Harris also. Harris, what would you like to say? You also part of the panel, so please give us your experience, your recommendations and suggestions.
Thank you, Surinder. So I think what's clear from this panel, everyone has a different formula, and when everyone has a different formula about what color staple height to use, that means that there's something very different for every patient. Now, for the last 16 years, I've been using Medtronic for my sleeves, 5 centimeters from the pylorus. I partially resect the antrum, not completely, because there's good studies showing that the antrum is important for gastric emptying. So if you are too radical with your excision of the antrum, you may get problems like reflux or regurgitation. But for the last 16 years, I've been using, for my sleeves, 2 purple 60s and the rest tan 60s. I've never done staple line reinforcement. I never oversew. And so far in my practice, I haven't had any leaks or bleeding complications. So that's my experience. The results are good. I haven't used any powered stapling technology. I must say, when I do my sleeves and bypasses, I compress for about 1 minute, not 15 seconds, 1 minute.
This is before you fire or after you fire the stapler?
No, before I fire.
Before, okay.
Yeah. It's like a ritual, and this is something I learned from observing Michel Gagné. He actually, it's on the internet on YouTube, you'll see him giving a promotional video for, I think, Medtronic, and he compresses a bit longer than that. And obviously that's to reduce the risk of bleeding. But I think this is kind of the point of having this panel session, because we're doing different things, but still getting good results. And what are the other ways we can decide what is the best staple height? I can definitely feel when I compress the stapler on the stomach, especially if it's a revision, whether it's the right staple height. But generally, this is my formula: 2 purple 60s and the rest tan 60s for a sleeve. And I haven't had any problems so far.
That's great. So is anybody using any sort of a sensor or artificial intelligence, like they say, like in the Signia stapler, it gives you some guidance? And I know that there are some companies in the world which give you information on the stapler handle to show you that this cartridge is fine for this stomach wall, and sometimes it will ask you to change the cartridge. So do you use any sort of smart staplers like this?
Well, I started using it because the company asked me to use it. The problem is when you get in and you are trying to save as much as you can. And you get a cartridge, and then the senior tell you or whatever that this is not the right one.
Yeah.
You should remove it and throw it probably, or use it at a later stage. So again, this is questionable concerning this issue. The problem is concerning the BMI, as we have to talk about it. The BMI itself does not tell you how thick is the stomach.
True.
But you should expect that with a higher BMI, that probably you have more fat, more yeah, probably. But you should observe and then decide, and not to do it only because of the high BMI. Concerning the pre-stress or pre-compression, not all stapler guns can compress.
True.
Well.
It's only what we know. The Ethicon guns compress.
Yes.
I don't know if there are other guns that X and Y also
They are
had a
trying to-
compression.
yes.
No, it had a good compression
Yeah.
when we used it yesterday.
So
While Medtronics doesn't have.
Yeah, they don't. So if Professor Higa was using the good compression guns, probably he would have acceptable results. But I cannot see with the Medtronic at least that we will have good compression if we want to use lesser height in this case. This is why I think that our advice to ourselves, to everybody, that to keep on using the same thing and not to venture with the white cartridge, at least at this.
So I'd just like to mention here that long ago, many people may not remember this, but when Medtronic was Covidian, or even before that was Tyco or US Surgical, it had a laparoscopic instrument with one movable arm, and you could place it on the gastric wall and would give you the thickness of the stomach. It actually was an indicator of the thickness, but you don't see it in use anywhere, and this was many years ago, so I don't think anybody has any experience with that. Yes, Imran, you
Yeah,
want to
just
say
a
something?
comment regarding compression. So what is my experience, or maybe we learn like this. So just when you will start and compress that, I must wait at least 1 minute. Then again, every shot, I must wait 20 seconds. So I don't, but really I can ask, so our stepper line is bloodless. As you mentioned, maybe Professor Higa, when he's using white and need, make more compression, I don't know, because I didn't see his surgery, but compression is effective, no doubt, and especially for our youngsters, this is the message. In laparoscopy, slow is always speedy, no need to go hurry and crush the tissue, then will take more time to make hemostasis.
So any other smart devices being used to gauge gastric wall thickness and to use the right cartridge? George? Anyone? Any other smart device anybody uses?
So I'm using, as I mentioned, Signia, but Signia doesn't have any.
Any other special devices?
I have never used.
Harris, do you use anything that gives you any?
No, I mean, the purpose of this panel was, I am aware and that there is some newer technology, optical technology, that when you shine the scope at the stomach, it tells you the thickness of the stomach.
So is that in use? Are you using it?
I'm not, no. I haven't seen it in clinical use, but I'm aware of some companies that have this type of technology, which is great. Because if you shine it at different parts of the stomach, it will basically be able to tell you the relative thickness of it. So obviously that will guide your... Because up till now, I think it's fair to say the majority of us are guessing, and we're hoping. And the real concern is, like, for example, patients who have had intragastric balloons, where the stomach can become quite thick after 6 months or 12 months, then you remove it, and then you do another operation. So in those patients, I would want to use, say, a black for my antrum, because sometimes the stomach is quite hypertrophied. But I'm not aware of any, besides Signia, which is extremely useful to tell you whether you've got the right staple cartridge or not. I'm not aware of any other devices or technologies in clinical use, but I'm aware of optical technology to assess the thickness of the stomach. I don't know if anyone else has any insights.
So after usage of the balloon, you're right that the gastric wall becomes thick, but if you do a surgery immediately, usage of black would be most sensible. But if you wait for a month at least,
4 to 6 weeks. Yes.
yeah, you wait for a month at least, then
Yeah, I would always wait 6 weeks. I would never do it. I would never remove a balloon and do a sleeve at the same time. Never. I would always wait 6 to 8 weeks. But even so, if they've had the balloon in for 6 or 12 months, there's balloons available for 12 months.
Yeah.
Sometimes that stomach is quite, especially the stomach, if the patient has lost significant weight, there may be some degree of outlet obstruction from that balloon, and that antrum can become very thick, especially in males. So I would never do this. I would never do the procedure at the same time as removal. Also, because the balloon is often covered by a lot of food residue, which I definitely don't want to staple across. I want to give it 6 to 8 weeks. But that's the type of situation where knowing the thickness of the stomach is important, because I've never, for a primary sleeve, I've never used a black. And a lot of the panelists, my expert colleagues, spoke about using black cartridges, but we were doing sleeves way before the Medtronics and Ethicon released the black cartridge. So that kind of tells you something, that you don't need the black. It's not essential for primary sleeve gastrectomy.
Yeah. So it seems obvious that the artificial intelligence enabled optical equipment is still yet to come into regular usage, because nobody else has any experience with that. And it's interesting to note that in the earlier years, the incidence of leak was much higher than it is now. And earlier years, people were using reinforcements with seam guard and peri-strips, and using tissue sealing with the glue, and of course suturing is still there, but people use it less and less these days. So in spite of not using additional aids now, the leak rate has come down. So I think the experience of the surgeon has improved so much that they are able to judge, or maybe after firing the stapler, if there's any doubt, they take proactive action, and that's why maybe leak rates have been brought down. So with this, I think we'll bring this to a close, unless Harris, you want to say any other last words about this, or anybody else has a brief statement to make. Harris?
I'd just like to thank you for really expertly chairing this interesting session. And I think as the companies bring their technology onto the market, it will become clear the value of these so-called optical technologies to assess gastric wall thickness, because I think they will be a game changer, especially for revisional cases especially.
True.
But again, thank you so much,
Thank you.
Surinder.
Anybody
And
has just
also the
one?
panel.
Yes, short remark.
I have one question to audience and the panelists. What about usage cartridge height in terms of revisional surgery? For example, if we want to convert from sleeve to bypass, it's quite interesting.
So revisional sleeve, I mean any revisional
revisional surgery, are we doing the same
any comments?
Definite revisional surgery is not initial, and we must be careful, and the tissue thickness is more. Again, you must know which part of that stomach you are going to do stapling, and we must select, and definitely we will try our best to take highest cartridge. So if you have green, I prefer green, and as Professor mentioned, JJ is a good, GRISP is a personal. So
the balance always is between higher staple height for safety, but you could have little bleeding.
Yeah.
Lower staple height, good compression, less bleeding. Watch the vascularity.
Yeah,
so some surgeons use ICG to check vascularity, but as we discussed, we have staple heights going from Kelvin Higa's white all the way to black. So I think what becomes more important is probably the surgeon's observation and the care Yes, Professor Mustafa.
I need to add a little remark. Definitely we're seeing much less leaks than before. It's not only our experience. I think that the companies have improved also on the staplers, but they are not bragging about it because some people might come and say, you gave us bad staplers before, so we'll see you for our leak. So this is why they are not bragging, but I think they have done a very good job concerning improvement.
I think that's a very important point. With that, yes, Professor, yes?
Please, I speak from Georgian, okay?
All right.
მე უყურებ კატრიჯებს ჩვენ საერთოდ კუჭს ელასტიურ ქსოვილს ვკერავთ მეტალის კატრიჯებით, რომელიც არ არის რბილი და არის მეტალის. გადავთარგმნის ის ტრანსფორმაცია. აქედან გამომდინარე, ჩვენ შეგვიძლია ისეთი კატრიჯი გამოვიყენოთ, რომელიც მოგვცემს მაქსიმალურად სიმკვრივეს, რომ არ გქონდეს სიზღლდენა. ანუ ჰემოსტატს მოგვცემს, მაგრამ ჩვენ უშვებთ შანსს, რომ გქონდეს უფრო იშემია და გქონდეს უკმარისობა. ამიტომ ყოველთვის ჯობია გამოვიყენოთ სქელი კატრიჯი, რომელიც მოგვცემს იმის საშუალებას, ჩვენ არ გვექნება იშემია იმ ქსოვილზე, კი გვექნება უფრო მეტი ალბათობა სიზდენის, მაგრამ მე მირჩევნია, რომ მეორე სართულის სლივის შემთხვევაში გავკერო და ამით მივიღო შედეგი. მე არ ვამბობ, რომ ყველა მეს გააკეთეთ, ჩვენ ასე ვიღებთ ძალიან კარგ შედეგს. დაახლოებით 1000 სლივის შემთხვევაში არ გქონია არც ლიქინჯი და არ გქონია არც სიზდენა. რაც შეეხება ბაიპას, როცა ჩვენ ანასტომოს ვადებთ კუჭს და ნაწლავს შორის, აქვე ორ სხვადასხვა ორგანოზე ვმუშაობთ. კუჭის ქსოვილი უფრო სქელია, ნაწლავის ქსოვილი უფრო თხელი არის. აქ პირიქით არის აბსოლუტურად, ჩვენ უნდა გამოვიყენოთ ესეთი კატრიჯი, რომელიც მაქსიმალურ კომპრესიას მოგცემს, რომ იქ არ გქონდეს არც ლიქინჯი და არც სიზდენა. იქ ყოველთვის ვიყენებთ ვასკულარულ, მედიუმ ვასკულარ კატრიჯებს. ბაიპას შემთხვევაში რევიზიულ ოპერაციებზე, სადაც გვიჭის ქსოვილის განსაზღვრა, ყოველთვის რაც შეიძლება მაღალ კატრიჯებს ვიყენებთ, მაღალი სიმაღლის კატრიჯებს. კი ბატონო, შავს და მწვანეს ხოლოდ.
ხო, აქ ჩემი აზრით ჩვენ უბრუნდებით ისევ იმ საკითხს, რომ ყველამ უნდა აკეთოს ის, რაშიც გრძნობს თავს კომფორტულად და
ვიღებთ მაქსიმალურ შედეგს.
მაქსიმალურ შედეგს, ხო, ანუ ჩემი აზრით, აი მე მაგალითად ეხლა კახას ვიცნობთ ჩვენ ძალიან დიდი წლებია. მე და კახა ერთმანეთს და კახა რაც მახსოვს სულ აკეთებს სიუჩინგს, ავთარსლივ და მე არასდროს არ გამიკერია ეგნაკერი, თუმცა ჩემი აი მე რაც მქონია სისხლენათა რაოდენობა ჩემ პრაქტიკაში არც ერთი არ ყოფილა ამ ლაინიდან, სტეპელაინიდან. არც ერთი სისხლდენა არ ყოფილა იქიდან, ყველა იყო ან პადეკონიდან, ან ტროაკარის ხვრელიდან. ან რომელიც საერთოდ არ დაგვიდგენია ოპერაციის შემდეგ რა იყო მიზეზი ამის, მაგრამ არც ერთი არ ყოფილა სტეპელაინიდან. ამიტომ მე მაგალითად აი აგენსტ ვარ კახაზე მაგ თემაში, რომ მე არ ვკერავ და არც გავკერავ არასდროს.
So did you say the gastric wall was thinner than bowel wall? Is that what you mentioned? Gastric wall was thinner than bowel wall? Gastric wall. Because that's what I heard you say. So because the small bowel wall usually is thinner than the gastric wall. I mean, just to say that. So yes, some brief points.
Okay, I have a question about using highest cartridge. Does the Kaha has any statistic of bleeding rate after using highest cartridge?
So
any statistic, any information about it? Because
I think what's happening is different regions, different surgeons, depending on where they are trained or what their perception is, will continue to use what they are comfortable with. It's a good thing if you observe things, make sure your patients don't have any complications, whether bleeding, forcing you to re-laparoscope, or leakage, of course, is a bigger problem. But at the end of the day, we have the experience of multiple surgeons, and since there is no randomized clinical trial or evidence-based situation we can have, it remains that every surgeon and unit will use what they are comfortable with. So with that, I thank you all, the panel and Harris for this, and we bring this session to a close. And over to Manana. Thank you.
Thank you very much. Thank you so much. It was very interesting.
Thank you very much. Really interesting section. Thank you very much. Now we have a presentation. And please, next presentation is Professor Mamuka Gonjulashvili, presenter. Thank you.
Hello, here.
I'm sorry, I'm beginning to speak in Georgian in our language, and then my assistant continue to English. მოგესალმებით ყველას ერთხელ, კიდევ ერთხელ და მინდა რომ წარმოგიდგინოთ ჩვენი მოდიფიკაცია, რომელიც ჩვენ სკლინიკაში გაკეთდა პირველად და მინდა რომ ერთი-ორი სიტყვით გითხრათ რა მიგიყვანა აქამდე. ჩვენ რამოდენიმე წლის წინ დაახლოებით 7-8 წლის წინ დავიწყეთ ისეთი ტიპის ოპერაციები, როგორც არის ბიპარციალური შუნტირება. ბიპარციალურმა შუნტირებამ დაგვანახა, რომ ის უპირატესობები, რომელიც აქვს ბუნებრივი გზით საკვების სვლას. კერძოდ, ბიპარციალური შუნტირება, როგორც მოგეხსენებათ, არის კომბაინი სლივ გასტრექტომიის და გასტრიკ ბაიპასის კომბაინი, ასე ვთქვათ და ჩვენ რომ ეს დავიწყეთ ეს ოპერაციები დავინახეთ, რომ აღნიშნულ პაციენტებს პრაქტიკულად აღარ ესაჭიროებოდათ არანაირი ჩანაცვლებითი თერაპია და ის გართულებები, რა გართულებებიც არის, როგორც პეპტიური წყლული, დაუშვათ ისევ და ისევ მალაბსორბციასთან დაკავშირებული გართულებები პრაქტიკულად გაქრა, ასე ვთქვათ. ჩვენ სულ ვფიქრობდით, რომ როგორ გამოგვეყენებინა დარჩენილი კუჭი მინი გასტრიკ ბაიპასის ოპერაციების შემდეგ, იმიტომ რომ პრაქტიკულად ამ კუჭის გამოყენებას კუჭი უსაქმოდ, ასე ვთქვათ, არის და ვერანაირად ბუნებრივი გზა, ვერანაირ მონაწილეობას ვერ ღებულობს აღნიშნულ საჭმლის მონელების სისტემაში და აღნიშნულის გამო როგორც წესი, როგორც კანონი უმეტესწილ პაციენტებს შორეულ მომავალში მაინც სჭირდებათ გარკვეული ჩანაცვლებითი თერაპია. აღნიშნულ იდეამდე მიგვიყვანა სწორედ იმ შემთხვევამაც, როდესაც ნაოპერაციებ პაციენტში ძალიან ძლიერი შეყურცებითი პროცესი დაგვდა კუჭის ფუნდუსთან და ელენთა პრაქტიკულად ორგანულად იყო დაკავშირებული კუჭის ფუნდალურ ნაწილთან და ჩვენ მინი გასტრიკ ბაიპასი შევასრულეთ და დაახლოებით სანტიმეტრი ნახევარი 2 სანტიმეტრი დავტოვეთ გადაუჭრელი, ანუ კავშირი ახლად შექმნილ კუჭსა და ძველ დატოვებულ კუჭს შორის იყო დაახლოებით სანტიმეტრი ნახევარი. კიდევ საუბრობ, აღნიშნულ პაციენტს ჩვენ უკვე ვაკვირდებით წელიწად ნახევარია და რეალურად შედეგი გვაქვს ისეთი, რომ აი უკეთეს ნუიტყვით, ადამიანი პრაქტიკულად ესე იგი წონისკლება ძალიან კარგი, აი ისეთი როგორც მინი გასტრიკ ბაიპას ერგება და პრაქტიკულად არანაირი ჩანაცვლებითი თერაპია და ის შივილები, რომელიც მას თანახლავს ამ პერიოდში, მას არ ქონია. ჩვენ გავითვალისწინეთ, შევხედეთ და აღნიშნული შემდეგ უკვე ეს აღნიშნული მეთოდიკა უკვე ჩვენ ვიხმარეთ 8 პაციენტზე და რეალურად ეს პაციენტები 3, 5, 6 და 7 თვის ინტერვალით ყავს ობზერვერობის ქვეშ, ასე ვთქვათ. და ჩვენ რა გვინდა ვთქვათ, ჩვენ არანაირ იმას რა ქვია დასკვნებს არ ვაკეთებთ იმდენად რამდენადაც ჯერ გამოცდილება ძალიან ცოტა წარმოდგენასა ჯერ არ შეგვიძლია ვთქვათ არც 3 წლის და არც 5 წლის გამოცდილება არ გვაქვს რომ საყოველთაოდ მოუწოდოთ ყველა ქირურგს აღნიშნულის კეთება და რეალურად ეს ჩვენ ზუსტად არც ვიცით წონის რევერსი როგორ იქნება მე იმედი მაქვს რომ არანაირი ზეგავლენას ეს არ მოახდენს მაგრამ ყოველ შემთხვევაში რამდენად გაიზრდება დაახლოებით 3-5 წლის შემდეგ ის დატოვებული ფანჯარა მაგრამ ყოველ შემთხვევაში ჯერჯერობით რასაც ვაკვირდებით აღნიშნულ პაციენტებს რეზულტატი არის ძალიან კარგი ეხლა მე ვთხოვ ჩემს ასისტენტს რომ წარმოგინდგითოთ ეს მოკლე პრეზენტაცია და შემდგომ თუ რამე შეკითხვები გექნებათ შევეცდებით რომ გაგცემთ შეიძლება ბევრზე ვერ გაგცეთ პასუხი კიდევ ერთხელ ვიძახი იმიტომ რომ ჯერ სათანადო გამოცდილება არ არის ამაში 8 პაციენტი და 10 პაციენტი ეს ამინც არ ქმნის მაგრამ ჩვენ ამ მიმართულებით მაინც გავაგრძელებთ მუშაობას და იმედი გვაქვს რომ რაღაცა დასკვნებს მაინც გამოვიტანთ ჩვენ რენტგენოლოგიურად შევისწავლეთ აღნიშნული პაციენტები ვნახეთ რომ 1/3-იც არა უფრო ნაკლები ბუნებრივი გზით გადადის ძირითადი მასა მიდის ახლად შექმნილი გზით რესტრიქციული ელემენტები საკმარისად მკვეთრად არის გამოხატული მაგრამ 1/3-ზე მცირედ უფრო 1/4 ალბათ დარჩენილ კუჭ გადის და ბუნებრივი გზაც ამ საჭმლის მონელებელ სისტემაში მაინც მონაწილეობას ღებულობს მადლობა
ბატონო მამუკა ერთს კითხავთ ეს ლიტერატურული მონაცემებით ვინმე აკეთებს მსოფლიოში თუ არ არსებობს ჯერ ხო? Okay.
So hello. I'm going to briefly emphasize and demonstrate this according to the case that Dr. Mamuka mentioned. There was a patient, 52-year-old, who presented with 51 BMI, insulin resistance, and we did the initial checkup, and the patient was admitted to the operating room to do the one anastomosis gastric bypass. So while conducting the procedure, unexpected discovery was made. The spleen exhibited severe adhesions to the stomach, making performance of one anastomosis gastric bypass non-viable. So faced with this challenge, surgeon made the decision to leave a small portion of the stomach connected to the esophagus while surgically dissecting the remaining sections. So as here you can see, traditional mini gastric bypass, in traditional methods, the whole food goes doesn't go into the stomach, and there's a high risk of malabsorption in lower BMI patients. In our method, there's a small connection in the proximal part of the stomach, and about 30% that we've seen on the barium study goes to the old way, to the traditional way, the natural way. So here is the laparoscopic image, and as you can see, it's about 1.52 centimeter connection with the esophagus. Here's a barium swallow study we did to confirm our idea that 30% goes in the stomach. So after 1 year of this, after 1 year, we did evaluation of this patient in 6, 8, and 12 months. And what was demonstrated is in 6 months we had 30% weight loss, which was about 50 kilograms. In 1 year we had 50% weight loss, which was about 90 kilograms. Replacement therapy stopped after 3 months, and the patient didn't have any issues with that. Also type 2 diabetes remission we saw by H1A2 was less than 6.5 after the operation, and before it was 8. And there was also improved lipid panel. So what are several potential advantages of this method? So there's a reduced operation time. It's much easier to perform. So we hypothesized that there's lower risk of complications, of course, that's the reason why we did it, because there's a lower risk of malabsorption and nutritional deficiencies. It's financially more profitable for the patient and for the doctor. It's less echelon is used. And there's lower risk of nerve damage, and it allows for revision of the residual stomach and performance of papillosphincterectomy. So our experience, as Dr. Mamuka mentioned, we implemented it in 8 patients who were fully informed and consented to the procedure. Like we had the opportunity to observe for only 2 to 6 months, and the results were comparable and aligned with the presented case that I just showed you. Weight loss was stable in all of the 8 patients. We didn't have any complications so far, since we are in a process of monitoring this patient. Replacement only was needed for 3 months, nutritional. Like, as again, I want to emphasize that we acknowledge that for the modification to gain wider acceptance, further studies are needed. Larger patient cohort is of course needed, and more time and more experience and more observation is necessary. So to sum it up, like the modification, we think that bridges the gap between safety and efficacy of one anastomosis gastric bypass by reducing the malabsorption risk while maintaining excellent weight loss outcomes. It offers practical solution for patients with anatomical challenges, such as we've seen in the adhesions in this patient, and it's more beneficial, in our opinion, for the patients with lower BMI. Around 38 to 40, we offer this operation. So in future, our plan to move forward is aimed to expand our study, gather long-term data, and refine technique. Thank you.
Thank you. I think it's some subjects, some attention subjects in this surgery. Good luck. We are waiting your results after 3-4 months, years, and I think everything will be okay. Thank you. Thank you.
Thank you, thank you.
I would proudly introduce also our team member, Anna Nikaberidze. She is endocrinologist and nutritionist. Please.
Hello everyone, do you hear my voice? Okay, it's truly a pleasure to stand in front of you. It's truly a pleasure to stand in front of you. I want to thank the organizers for letting me participate in this conference. So as for the presentation itself, I can promise I'm going to share some groundbreaking discoveries here with you that you are unaware of, but I will try my best, and I do hope to shed a light on a specific aspect of bariatric care, which is the pre-surgical counseling and its importance. And I will try my best to show it from a little bit of different perspective. Before I start demonstrating I will say a couple of words about the bariatric surgery, the effectiveness of the bariatric surgery, the challenges, and the potential causes of failure. Sorry. So, as for the bariatric surgery itself, we all agree that it's an accepted standard worldwide, and over 600,000 surgeries are done every year around the world. And there are, of course, the effectiveness of the surgery is quite high, but there are still some challenges. For example, the suboptimal weight loss, which is mostly observed at 1 to 2 years after the surgery, and additionally the weight regain statistics, which are commonly seen somewhere after 5 years from the surgery. This slide compares two most commonly done procedures, such as sleeve gastrectomy and gastric bypass. And if you don't mind, instead of that slide, I will use the graph for better visual aid to demonstrate the numbers of effectiveness on one hand, and on another hand, some certain challenges. For example, you see that effectiveness, the excess weight loss percentage is quite high in both cases. Some were 70% for gastric bypass, some were 60% for the sleeve. But as for the weight regain after somewhere 5 years is 10 to 15% for gastric bypass and approximately 25 to 30%, on average 25 I would say, for the sleeve gastrectomy. As for the failure rate, overall failure rate is 10 and 20%, well, respectively, yeah? And there is an intriguing question. Well, what can be a potential cause of failure? Is that a surgery or surgeon himself or something else? And turns out, and research shows that the issues mostly lie not in the surgery or surgeon, or the skills of the surgeon, or the failure of it, but mostly the behavior changes of the patient, especially the increased caloric intake, lack of physical activity, psycho-emotional stress, and additionally going back to the old eating habits. And that brings us to the topic which I want to discuss with you today. What are the expectations, like initial expectations of the patients when they first hear about the surgery? At our endocrine department, we had this kind of cases multiple times when a patient with quite well-controlled diabetes and not too severe obesity, maybe just a BMI of 32, not more, comes in for a regular checkup and monitoring of the treatment, and towards the end of the consultation asks the question which might sound like this. Doctor, have you heard about this surgery which they say cures everything, the diabetes of course, and let us throw away all the medications? Well, that's initial expectations of patients in most of the cases. They somehow expect that the results will come without effort, or minimal effort at least, that the surgery itself is a fix for everything and they will be completely medication free. But we know that reality is a little bit more complicated and we have to align their expectations with reality. So we have to show the patients that results come, and we all indeed agree that bariatric surgery has transformed the lives of many people, and results will come, but that requires great effort and long-term commitment, that the surgery itself is not a fix, it requires lifestyle modification and adjustment. And they won't be completely medication free because they will at least require multivitamins and supplements, without which the severe deficiencies and complications may develop. Okay, I think now it's the time to break down the key components of pre-surgical counseling and speak about their benefits. So what are they? The patient education, of course, the personalized assessment, also lifestyle modification, micronutrient management, and so on. Let me break them down step by step. Starting with the patient education, well, this is quite important step. Patients have to understand what are the potential outcomes and limitations of the surgery, and they have to also understand that bariatric surgery may not be the best option for everyone, and there are several subtypes which must be chosen individually for certain patients. And as for the importance of follow-up visits, well, they have to understand that regular follow-up is extremely important for monitoring the progress of the weight loss, for example, and improvement of the disorders, and to manage the medications, to change the medication, and address any potential complications, of course. As for the personalized assessment, I will divide this topic into two halves. First is the medical assessment, which includes the multidisciplinary team approach, additionally lab works, all the tests which are, for example, recommended by ASMBS guidelines, such as lab tests, imaging, screening tools, which you are all familiar with, that's why I'm not going to break them down. And the key message which I want to mention here is to evaluate patients properly, and that the thorough medical assessment is necessary for discovering the contraindications and choosing only eligible patients for the procedure. As for the second half, well, that was our ASMBS guideline protocols for pre-surgical screening. Well, you all know this. As for the second half of the personalized assessment, here I want to emphasize the assessment of eating disorders. Turns out that eating disorders are quite common among bariatric surgery candidates, such as binge eating disorder, night eating disorder, also food addiction, additionally bulimia nervosa, and you see the persons there, right? And turns out that addressing these problems before the surgery is extremely important, because uncorrected and not addressed problems will worsen the outcomes after the surgery and will make the patients face greater challenges post-operatively. As for the management of the problem, of course, that includes the mental health support and not only treating the problem and addressing the problem only prior to surgery, but also following up the patient and trying to prevent the recurrence, and in case of recurrence, manage it after the procedure. As for the micronutrient management, well, it is another critically important aspect of bariatric care, because we see that certain types of micronutrients are more prone to be deficient before the surgery. And what we have to do is to check their levels and definitely correct them. Why? Because any uncorrected deficiency can easily and rapidly worsen after the surgery, and we all know that faster the level of the nutrient drops in the bloodstream of the patient, the less adaptive the patient's body is to the change, right? What do we check? We of course check the most commonly deficient vitamins, but additionally we have to add tests if we have a doubt about some other specific vitamin deficiency. How can we do that? By thorough history assessment and asking the patients if there are any symptoms, like manifestations of different vitamin deficiencies and so on. And as for the postoperative period, the patients have to understand that because of the surgical intervention, their gut anatomy is quite changed, and that changes their absorption rates of certain vitamins. That's why they will require, definitely will require micronutrient, multivitamin supplements plus calcium citrate. Why citrate? Because it's better tolerated and absorbed than carbonate, for example. And if there are any additional deficiencies, like over deficiencies, we can add extra doses too. Understanding this is very important and crucial, because we ourselves have witnessed how non-compliant patients developed severe issues, neurologic issues, deafness, peripheral neuropathy, which prevented them from even from walking. Quite young patients, by the way, not elderly ones, even though the age is one of the risk factors, and also anemia, bone loss, and many other complications. And unfortunate fact is that exactly those patients were the ones who were not fully informed about the importance of adherence to multivitamins before the surgery. That's why we are highlighting this right now. As for the multivitamins, the guidelines give us specific numbers and amounts which must be inside the multivitamin, bariatric multivitamin. These are usually much higher numbers than the standard ones. That's why choosing the exact multivitamin regimen for the patient is also necessary. As for the lifestyle and habit adjustment. First thing that probably comes into your mind is smoking. Smoking is a thing we have to advise everyone to quit, because smoking itself can increase the risk for poor wound healing, for a marginal ulceration, and worsen the outcomes. As for the bad eating habits, it's quite common in bariatric surgery candidates. That it's not surprising at all. That's why the pre-surgical evaluation must include and involve the eating pace and pattern, the meal composition, and also liquid intake. And the advice we can give to the patients is changing the habits not only after the surgery but before the surgery too, because earlier you implement those changes, much better outcomes you will get. So what are those? For example, dividing the food into 4 to 6 meals per day. Additionally, trying to practice so-called mindful eating, which means chewing slowly, stopping eating while you feel comfortably full, right? Utilizing smaller plates, and so on. Additionally, choosing nutrient-dense products over caloric-dense products, and avoiding the caloric-dense drinks, of course. And finally, increasing the hydration, but always keep in mind to separate liquids from the meals. As for the weight loss optimization, of course, post-surgical optimization is another thing, our big and major goal, but turns out that pre-surgical weight loss optimization can be also helpful. How? For example, the decreased size of the liver or decreased amount of fat can actually give surgeons better visual field and decrease the risk of complications. Another good thing is health benefits, such as better glycemic control, which may improve the wound healing process, better respiratory and cardiovascular condition during anesthesia, and overall changing behavior as early as possible is always the best option. As for post-surgical weight loss optimization, the patients always have to know what kind of diet they will have to follow after the surgery. Of course, there is no one strict rule or one strict recommendation what kind of diet we have to choose for our patients, but there are certain kind of rules which we have to follow. And I will try to demonstrate those rules with the help of our approach, the 5-stage diet, in which the major rule is gradual increase of size of the portion and gradual change of the texture of the food, of course, according to the tolerance of the patient. So here you see the first stage is early postoperative period, most of the hospital stay, only clear liquids and only saline infusion. Then the second stage, which already includes the full liquids, implements full liquids in it, lasts only for somewhere for 2 weeks, but depends on the patient's tolerance, of course. Then we have the third stage, which lasts for another additional 1 month, and now soft foods come into play. And finally, we have fourth and fifth stages, where both solid foods are already the major components of our diet. But the difference between the stages is, of course, the period. One is before the 6 months, and another is after 6 months from the surgery. And the difference, of course, lies in caloric intake too. So we gradually increase the amount and gradually change the texture, and it always depends on the patient tolerance. And we always have to emphasize the amount of protein intake, emphasize the importance of hydration. We have to teach patients what is damping syndrome, how to recognize its symptoms and how to prevent it, and so on. Well, patients have to have thorough information about everything. And finally, to summarize my slides, today we just discussed the importance of patient education and additionally importance of personalized assessment before the surgery. And if we discuss any kind of problems like that's right. Any kind of problems like vitamin deficiency or eating disorders, we always have to address them before the surgery. Additionally, the micronutrient importance and the importance of adherence to their multivitamin regimen. Also, the challenges which come into play if there is an improper lifestyle modification and the patients come back to old behavior. And finally, I think we can all agree that better education, better understanding of the procedure leads to better adherence, durable weight loss, and less complications. Thank you very much for your attention.
Thank you. Thank you.
And at the end of my presentation, I want to thank our medical team, our endocrine and surgical team, especially our head of department, endocrine department, Nino Gabitsashvili. Thank you for your invaluable support. And I want to thank Dr. Gams, who is not here with us anymore, but I want to emphasize that he helped us a lot to understand the management of bariatric patients even better, much deeper, and also somehow helped us adopt more comprehensive and patient-centered approaches in both pre- and post-surgical care. Thank you so much.
Thank you. And one of the endocrinologists, Dr. Katie, who help us to before and after surgery our patients. Thank you. For very interesting presentation because pre-operative period and after surgery, without your support, our patients won't be healthy. Thank you.
Thank you so much.
So our next presentation presenter is CMO of American Hospital, Dr. Irakli Gogokhia. I hope that he will join now from the Batumi. So welcome, Irakli. His topic is anesthesia and artificial intelligence, analyzing the bariatric surgery patient from the different angle.
Can you hear me?
Yes, of course, but I can't see you.
Yeah, I'm trying just to set up my system here. 1 second.
Okay.
Please make sure that I have access
Hello?
to share my screen.
Yes, yes.
We see
yes,
you
everything
now.
is okay. You can
yes,
continue.
we can see you.
Do you see my screen?
No.
We cannot see your presentation.
Now you will see.
We can't see your presentation. Yes. Just.
Okay. I'll try again.
Yes.
See my screen, right? So thank you very much to giving me chance to be part of this great meeting. So I'll try to get very quickly and very productively all information which is related with anesthesia and in bariatric surgery practice. So last especially 2 years are mostly in bariatric surgery. Before I was doing mainly cardiac anesthesia, and now last 2 years I switched to be interested in bariatric surgery, and I have very good data and very good tips and tricks of anesthesia in bariatric surgery, and with pleasure I will share with you. Can you see my screen, right? I will start. Great, because I will not take much time.
Dr. Irakli, could you make us just more visible? There are just not full screen.
Now it's full?
You can, as you like. Now you can do as it is, because we see also slides and it's not...
Okay, if you see, I can go on.
Okay,
I
yes.
Take your time. This picture demonstrates the first anesthesia. This is Lord God taking rib from the Adam to make Eva.
იკა ბოდიშით და სლაიდ შოუს დააჭირეთ ხელ და გაიშლება თქვენი სლაიდები მონიტორზე პატარაზე ჩანს.
კი, მაგრამ არ შლის, რა გავშალე და არ იმაშობა, რა ვიცი.
Okay, continue please. Okay, sorry.
ეხა ჩანს. So anesthesia before surgery, before anesthesia, you see here and that this amputation of the leg and its real picture, and the picture demonstrates that a patient has big discomfort because he's in pain, and also surgeons are in the hurry, and this situation cannot be possibility to do teaching for other surgeons, and it's very tough condition for everyone who is participant in this procedure. So you see the difference now. This is the first general anesthesia demonstration in Boston University, Massachusetts. The patient who had a tumor neck and they are removing by ether anesthesia. And since then we started to develop our field, and the last 2 decades, especially in bariatric surgery, and you have very specific and quite difficult patients systematically and with many comorbidities, and it takes really, needs to understand to take special care with preoperative assessment and intra and postoperative as well. So this is the credentials and privileges for the team who is working in bariatric surgery. And on one side you see surgeons, to the second the anesthesiologist, and the surgeon needs to have 10-year general experience. This is, by the way, I took it from international standards of accreditations of the hospital to have a bariatric unit. So 10-year general experience, 5-year minimal invasive surgery experience, and 50 to 70 cases at least per year, and credential must be reviewed annually, you know, because you have to have the continuity according case-based experience. Anesthesia is a 5-year minimum general experience and training for difficult airway management, because mostly the incidence of the difficult airway is quite high in bariatric population, in bariatric surgery. All anesthesiologists needs to have at least 50 cases per year to keep the skills, because I'll show you the slides which can demonstrate the difficulties of anesthesia management, and you'll understand what I mean. And of course, credentials must be also reviewed annually. So, main our goal to achieve the analgesia, hypnosis, and relaxation, and nothing new here. But you know, it has a different way how to achieve this with which kind of monitoring system. Wow, its slide doesn't move. Why? Oh, sorry. Now you see movement. My slide changed or not, my friends?
Yes, yes.
Now it's changed, right?
Yes.
So this is a patient, and you can understand how difficult to manage technically when you are anesthesiologist, to make a proper induction of anesthesia, to put the lines, and to make intubation, and then to maintain the respiratory therapy during procedure. So that's why today, very actively in our society, we are speaking about bariatric anesthesia management, which is quite difficult. I want to show you a couple of slides, what happens with the physiology of the respiratory system. We have high oxygen demand because of obesity. Actually, obese patients are consumption of the oxygen is more high. So we have elevated work of breathing because of respiratory muscles insufficiency, and we have changes in the lung compliance, and we have low functional residual capacity and high closing volume, and of course ventilator perfusion abnormality, which finally caused the hypoxemia. So we have also changes in the cardiovascular system. We have elevated left ventricle end systolic pressure and right ventricle end systolic pressure, and stroke, systemic vascular resistance also high because of hypertension during metabolic syndrome. We have secondary pulmonary hypertension because of mainly all obese patients tend to have COPD and Pickwick syndrome, which leads to have pulmonary hypertension, and also high hypoxemic drive, which means that all those patients has high PCO2 in the blood, and it also elevates pulmonary hypertension due to increase of vascular resistance of the pulmonary bed. So, what is the key points of the management? It's you have to be well equipped, and your monitor system must be with high standards. You have to set up very good anesthesia workstation with the team. You have to have all the time someone next to you. I mean, second anesthesiologist, where you're taking super obese patient, which like a BMI more than 50, 55, and you have because mainly it's related with technical problems, and you will need extra hand. Integration anesthesia system, and today we're actively using artificial intelligence in anesthesia, and especially in bariatric surgery. And you will see this all for my next slides. So, of course, we have some changes in the drug dosage, and we almost are using all standards like a total body mass index and ideal body weight, and we are using also limb body weight. It depends on the agents which we are using, and mainly we are using sedative agents, muscle relaxants, opioids, and others. So regarding monitoring system, we have ASA. The ASA means American Society of Anesthesiology has the basic standard monitoring for each patient who is going to have general anesthesia. But sometimes we need extra additional monitoring for patient who has comorbidities with the cardiovascular system or respiratory tract, and it can be invasive monitoring and sometimes advanced monitoring systems like a pulmonary arterial catheters or to measure the cardiac output, especially patient who has obesity-related heart failure, and we are making surgery on him. So we need to control the sleep because the risk of averness is very high in obese patients because the volume of distribution of the all agents which we are using is different, and the peak concentration in plasma changes dramatically in small period of the time. And the gold standard is to manage the bariatric patient is to understand the level of the anesthesia, and this is bispectral monitoring, which effectively manages the side effects like averness or part suppression, or and it can control the extra cost of our agents and OR time as well. We are making extubation more fastly than in normal condition without bispectral monitoring. We are also avoiding legal issues and postoperative delirium and prolonged hospital stay. And legal issues related, if patient is hearing everything, they can sue you and they can get some money from the hospital, and it's really problem in every hospital today. Postoperative delirium can be caused by the BART suppression. It means once patient is waking up and you are giving a big amount of the bolus of intravenous agent, you can cause very deep anesthesia, which we call BART suppression, and it damage some neurons, and the patient can be with delirium after surgery. And all those issues are prolongs the hospital stay, of course, finally. Still my slides are not changing, or you see my slides?
ყველაფერი კარგად ისმის.
სლაიდებიც იცვლება, ხო?
იცვლება კი. Fully arari, მაგრამ
okay, the BART suppression, this is, you see here the EEG, which is also comes with the bispectral monitoring, and you are controlling the brain activity during surgery, and if it's low, it means you have very deep anesthesia, which is not needed actually, which can prolong OR stay, because today all patients are extubated on the table, and it's quite effectively managed by bispectral monitoring, especially when the OR management time is well done in the hospital, and we are controlling every hour because especially in the day when you have several surgeries in the same room and you need to effectively utilize your OR time, it's very helpful. BART suppression is also prolongs the hospital stay because the patient can have some cognitive dysfunction, there's a delirium or agitation, and we need to control all of these problems. This is a target controlled infusion pump, which is today very actively used in bariatric and other surgeries, which is done with total IV anesthesia, and it means this syringe pump has artificial intelligence inside and gives you peak plasma concentration of the agents which we are using during surgery. And with combination of bispectral monitoring, you know what is the concentration of the drug in your blood, and you know also the deep of your sleep, and it's like a mutual effect finally leads to have very controlled anesthesia. This is an aero monitoring, the train of 4, which is controlling our muscles paralysis and relaxation during surgery, and the relaxant agents are calculated by ideal body weight. We don't need to give to the patient according total body weight, and also we are controlling during surgery how our patient muscles are relaxed, and also it effectively manages OR stay and post-operative care stay and hospital stay as well. So, difficult airways, one of the biggest problems in bariatric surgery, and all hospital needs to have difficult airway setting with all equipment. And mainly today, like a gold standard is to have the glide scope. It's a video assist laryngoscope for difficult airway management, because incidence of difficult airway related with obesity is very high in terms of personally, I had maybe 10 times difficult airway, and the 3 I remember definitely it was the bariatric patient. It means it's quite often happens, and you need to be fully equipped to manage this situation. I need to attend your attention. I need to take your attention here on this slide. This is ASA classification versus mortality rate. Mainly bariatric patients are 3, ASA 3, because if we have obesity with related some systemic disease like a metabolic syndrome, already it's ASA 3. If it's severe, it's ASA 4, and you see mortality rate 1.2, which is not low, and it means from 100 patients, 1.2 can die. And if it's 4, it comes to 8%, and that's why all teamwork is very important to have good bariatric team, which includes endocrinologist, anesthesiologist, surgeon, physiotherapist, nutritionist, and other stuff related with other comorbidities. And all teamwork makes this risk management more efficient. I need to show you also a SA classification with, we already had this slide. I want to show you ERAS guideline for bariatric patient, and mainly I need to focus here for to give the carbohydrate before surgery, and opioid sparing anesthesia, which is very multimodal opioid sparing anesthesia or opioid free anesthesia, which is very effectively today we are using in bariatric surgery, and it has really quite better result than opioid-based anesthesia. This is ERAS guideline, all points which we need to address to the bariatric patient. Carbohydrates are very important to decrease the insulin resistance after surgery. I want to show you also Aldrete scale, which we are using to discharge all patients from the post-operative care, and you see the points of this scale. This includes respiration, SpO2, means saturation, consciousness, circulation, and activity. And if we are using this scale and patient meets the standards and you are discharging from the post-operative care, secondary complications of anesthesia is very low. Respiratory depression in the patient ward or readmission in ICU, etc., etc. It's quite low, and today we are using this for all patients. Transversus abdominis plane is very effectively used today for bariatric surgery or in also all abdominal surgery, and it works very well with to make the opioid-free anesthesia. And our hospital has this standard, and today we are using this. We even had a study which included 103 patients. We compared this with with opioid-based anesthesia, and endpoint was extubation time, OR stay, post-anesthesia KNU stay, hospital stay, post-operative pain, post-operative delirium, post-operative nausea and vomiting, and post-operative neuropathy. And we published also this study, and we got really quite good results with opioid-free anesthesia and bariatric surgery. This is, can you see this video? By the way, I have all rights to show this video. I asked the patient, and it's no problem. This is the procedure of the transversus abdominis plane block, how we are doing. You see external and internal oblique, and down you see the nerve. And we need to get there and to inject the local anesthetic, both sides, bilaterally, 20 cc of 0.25% of bupivacaine, and with dexmedetomidine, which is also a new anesthesia agent for opioid-free anesthesia, works perfectly. This is our patient who has severe COPD and CPAP machine at home.
ტექნიკური სამსახური დაგვეხმარეთ, თუ შეიძლება გაიჭე და აღარ მუშაობს. კავშირი გაწყდა როგორც ჩანს. არც ჩვენ. შესაძლებელია. We will call Dr. Irakli and ask about this. This presentation is the last presentation today, and we finished today's our meeting. And I want to tell you the biggest thank you, and I will tell you again and again. Thank you for your time, for all of the colleagues. And it was very interesting. But really, I think surgical conference is very interesting than therapeutical actions. Because we practically show some subjects, and we can get more information. I think maybe it's my personal informations, but thank you. And before closed our conference, I want to ask surgeons the one question. We know and do not one surgery method. Sleeve gastrectomy, OAGB, Roy-and-Y gastrectomy, SASIS, SADIS, VPD, etc., etc. I have one question. What is the subjects, some criteria who help you to choose the for particular patients, which method we have to use? Please.
Okay, so we go through a detailed history, so we understand the lifestyle of the patient, the habits of the patient, their family circumstances, and what sort of exercise they like, they don't like, whether they have craving for sweets, etc., etc. We take history about their personality. Do they have a calm mind, or do they get angry fast? Are they very emotionally sensitive? Are they perfectionists in life, creating more stress for themselves, anxiety, stress, etc.? So this is the individual factors of the patient. Then we check with all the investigations, especially we're looking for fatty liver, we're looking for dyslipidemia, uric acid, diabetes, hypertension, etc. Now, based on all these, we will advise the patient and the BMI, all that, as to what surgery is the better one we think. Then the patient says, I prefer that because my cousin or uncle had that. So then we have a discussion and we say, okay, if you insist on that, remember you may have weight regain later or your diabetes may not go away, etc. So if you're ready for that, that's fine. And when a patient is low BMI and diabetic, our only procedure to do is the duodenal ileal interposition with a BMI adjusted sleeve. That's the only one.
Yes, of course. Yes.
Once they have morbid obesity, with diabetes or without diabetes, then we have a whole array like the sleeve and all these. Now we also check what is the chances of follow-up, how they will take nutritional supplements or not. That is why we have settled with a bypass procedure that is more proximal, so more of jejunal bypass rather than going to the ileum directly, because that is more malabsorptive like the SASI or SADI, and that is how we choose and suggest.
Thank you very much. Thanks. ბატონო, გაბა თქვენ რა კრიტერიუმებით აფასებთ? აი რომელ პაციენტს რომელი ოპერაცია უნდა გაუკეთოთ? აი რომ მოდის. აი რამოდენიმე ოპერაციის ტიპს ვაკეთებთ, sleeves, bypass, minivasi bypass, თქვენ მოდიფიკაციას. აი რა კრიტერიებით ირჩევთ მომავალს?
პირველად კაცრავად აი ბატონის სულენდრა უგალე, აი აკვანი მეტაბოლური ქირურგიის დაირწა 2011 წელს 12 ბატონი უგალე როდესაც ჩამობრძანდა საქართველოში და მაშინ შევასრულეთ პირველი მეტაბოლური სუფთა მეტაბოლური ოპერაციები, ეს იყო ileal interposition-ი, ნაწლავების ინტერპოზიცია. Ну, თურქეთმა და ჩვენ მაშინ ერთდროულად დავიწყეთ ეს ოპერაციები. ბატონი სულენდრა იყო ამის მან თურქეთშიც მან დანერგა ეს ოპერაცია და საქართველოში პირველი 3 პაციენტი ერთობლივად გავაკეთეთ. ოპერაცია იყო საკმარისად არის უпростоრეთ საკმარისად რთული, დაახლოებით ჩვენ მაშინ დაგვჭირდა 6-დან 7 საათამდე. მერე ბატონი რო წაბძანდა ინდოეთში, ისევ ჩვენ გავაგრძელეთ ეს საქმიანობა და პირველი ოპერაციას 9 საათი მოუნდით. 9 საათი ხო წარმოგიდგენიათ? ეს სრულად ლაპაროსკოპულ რეჟიმში. შემდგომ დავხვეწეთ, ასე ვთქვათ, ეს ოპერაციები და ჩამოვედით 6 საათზე. 6 საათის განმავლობაში ვასრულებდით და პირველ წელს გავაკეთეთ, შევასრულეთ 25 ეს ოპერაცია. ანუ ფუძემდებელი, ასე ვთქვათ, საქართველოში მეტაბოლური ქირურგიის გახლავთ ბატონის სულენდრა უგალე და ეს ჩაწერილია ანალებში. ქალბატონი ნინო ჭუმბურიძე გვედგა ჩვენთან ერთად, ქალბატონი მაკაკვირიკაშვილი სათავეში ამ საქმიანობას და მაშინ რომ შემოვიარეთ მთელი საქართველო, ჩვენი ამ ვინ გვიჯერებდა კაცო რომ მეტაბოლური ოპერაცია თუ იყო შესაძლებელი, ყველგან ვიყავით. ყველგან ვიყავით და ერთადერთი ადამიანი ბატონი მაშინ რამაზ ყურაშვილი, რომელმაც მოგვისმინა და რომელმაც მიიღო ეს ჩვენი ინფორმაცია, რომ შესაძლებელი იყო ოპერაციის გზით დიაბეტის, მეორე ტიპის დიაბეტის კურნალობა. Ну, დღესაც კი ვთვლი, რომ საუკეთესო მეთოდი როგორ მყარი რეზულტატი არის აქვს სწორედ ნაწლავთა ინტერპოზიციას. ყველაზე მყარი, ყველაზე აი დღესაც გაკეთებული ის ოპერაციები, რომლებიც არის ჩვენ მაშინ რუსეთიდან ჩამოსულ ხალხს, დღესაც მადლობას გვითვლიან, იმდენად კარგი რეზულტატი აქვს. Ну, მაგრამ კიდევ საუბრობ, ოპერაცია განისაზღვრება სირთულის მიხედვით, სიმძიმის მიხედვით და უსაფრთხოების მიხედვით. ყველაზე უსაფრთხო ოპერაციად მე მაინც მიმაჩნია ოქროს სტანდარტად აღიარებული ამერიკის, ეს არის მინიგასტრიკ ბაიპასის ერთთანასწომოზიანი მინიგასტრიკ ბაიპასის ოპერაცია. თუმცა რასაკვირველია ორანასწომოზიან ოპერაციებს თავისი ხიბილი აქვს, თავისი დადებითი თვისებები აქვს.
თუმცა ბოლო მაინც ორანასტომოზიანია ყველა
საბოლოო ჯამში.
შიხრის მაინც
ნუ ჩვენ ხო გეუბნებით რამოდენიმე მეთოდი ძალიან გული მოგვტაც ასე ვთქვათ ბიპარციალურმა შუნტირებამ. აი იმდენად კარგი ოპერაციებია, იმდენად დახვეწილი ოპერაციებია და ფიზიოლოგიური გზა რომ არ იკარგება, წეგან მე ჩემს გამოსვლაში ვთქვი, ფიზიოლოგიური გზა როცა შენარჩუნებულია, ადამიანი რასაკვირველია არანაირ გამარჯვებიდან ჩარევას არ საჭირო. შეშანიშნავი რეზულტატებია, როგორც მეტაბოლური მხრივ, ისე მალაბსორბცია საერთოდ არ არსებობს. ასე რომ უმეტესწილად ჩვენ შემთხვევაში ჩვენ ხმარობთ მაშუნტირებელ ოპერაციებს. ძირითადად მინიგასტრიკ ბაიპასის და სუფთა ბაიპასის ხრი, თუმცა უარს არც ერთზე ვიძახი და არც სლივსაც თავისი ჩვენებები აქვს. აი ჩვენ ძალიან კაცრ ჩვენებებს უყენებთ და მაგრამ მიუხედავად იმისა, რომ მაშუნტირებელ ოპერაციას უფრო პრიორიტეტულად მიიჩნევთ, სლივის გაკეთებად ხშირად გვიწევს. ჩვენ ამას ყველაფერში ქალბატონი მაკა გვეხმარება კვირიკაშვილი და ის გვირჩევს ხოლმე და ის გვეუბნება ამ შემთხვევაში ეს ჯობია. მადლობა.
Yes, thanks. Thank you very much.
სხვათა შორის მინდა დავამატო, რომ ეს ყველაფერი ბატონი სურენდრასგან ვისწავლეთ და ბატონი სურენდრას ამბავი იყო ძალიან ქალბატონ მაკასთან ერთად თანამშრომლობაც ძალიან სასიამოვნო იყო. დიდი მადლობა ბატონო მამუკა, რომ ყო ეს ისტორია. კი, მაგრამ ნინო რა თქმა უნდა გუშინაც იყო ჩვენთან მოსული. მე დაუძახე ყველა იმ ადამიანს, ვინც ჩვენთან იყო თავიდანვე ჩართული და უბრალოდ იმის თქმა მინდა, რომ ბატონი სურენდრას დამსახურება და სხვათა შორის ნიკა გვახარიესი თავიდან როგორც დაიწყო ეს პროექტი. ბატონმა ნიკა გვახარიამ იყო თავიდან შემოიტანა თბილისის ცენტრალურ საავადმყოფოში ამ ხორნალობის შესახებ და
2007 წელს ჩაატანა პირველად ლაპარასკოპიული ოპერაცია საქართველოში ნიკა გვახარიამ.
მაგრამ მე უბრალოდ იყო მეორე ტიპის დაბალწონიან პაციენტებზე და ზუსტად მაშინ მოხდა ის როც მოხდა, რომ გამიგშვეს ჰაიდერაბადში გავიცანი ბატონი სურენდრა და აი აქედან არის ეს ჩვენი ყველაფერი ერთად. დიდი მადლობა ყველას. ეხლა ამჟამად ფაქტიურად დაიხურა და მინდა ბატონ ჰარის გადავცე სიტყვა, იმიტომ რომ ის ბატონი ჰარისი არის ჩვენი სიმპოზიუმის მთავარი დირექტორი და სულის ჩამთქმელი. I would love to again thank you very much Dr. Harris, because we are now just finalizing our conference and we have also some certificates for our international guests, and please just that you were making a final speech for this conference and make also your some remarks about how it was and what is your wishing for us. Thank you very much.
Well, thank you so much, Manana. This has been an outstanding 62nd IBC Symposium, 31st in Europe. And again, it's a great honor to do this meeting in collaboration with all the surgeons from Georgia, but also the international guests. It's a great honor. Thank you to X&Y Medical for making this possible. And I hope it's been highly educational. I've certainly learned a lot. I've been up since 4 a.m. here in London, and I hope in the future I come to Georgia to be with you in person. But thank you again for the privilege to have this symposium at your meeting. It's been a great honor.
Thank you very much. It was a great experience to have such opportunity and such challenge. Also about Georgian character and European also timing. So I think that more or less we managed, and we will make it better next time. Thank you so much.
Thank you. Thank you.
Thank you.
უბრალოდ მინდა ბოლო იქიდან გამომდინარე, რომ ძალიან ბევრი დამსწრე არის. აქ ჩვენ გვყავს 3 საერთაშორისო სპიკერი და უბრალოდ მინდა რომ როგორც ბატონმა მამუკა თავხელიძემ ინება ოფიციალური სერტიფიკატების გადაცემა იყოს და დანარჩენი ყველას დაბეჭდილი სერტიფიკატები, იმიტომ რომ ორ ენაზეა და ცოტა დიდ სირთულეს წარმოადგენდა ჩვენთვის ინგლისურად გვეთარგმნა ყველა სახელი, ვინც არის დარეგისტრირებული დღეს ჩვენს კონფერენციაზე. აქედან გამომდინარე დაიბეჭდება და ორ შაბათს, სამ შაბათს გექნებათ ყველას. გვაქვს თქვენი საკონტაქტო ნომრებიც და ყველაფერი. დიდი მადლობა და უბრალოდ სიტყვას გადავცემ ბატონ მამუკა თავხელიძეს.
უშაობს ეს ხო ესე იგი თავი მოგჭერი მანანა ხა შენ სირთულეაო თარგმანიო თარგმანი კი არ არის სირთულე ჩვენს უბრალოდ სახელი და გვარი თარგმანი არ ვაკეთებ ხოლმე ჩვენ თვითონ თუ არა გვაქვს დედანში ინგლისურად წარმოდგენებს ზოგი ისე იწერება ზოგი ასე რომ შეიძლება ზუსტ თარგმანი არ გამოვიდეს ასე
დიახ ზუსტად ეს
ჩვენი ბრალი არ არის ბატონო
არა ნამდვილად არა ბატონო მამუკა რას ვლაპარაკობთ
მე მინდა არა გამოვიდა დავიწყოთ მე მინდა კიდევ ერთხელ დიდი მადლობა მოგახსენოთ მობრძანებისთვის გავიცანი ხა ბატონი ყურაშვილი გავიცანი სახელი და გვარი თუ იცნობდი მაგრამ პირადად არ ვიცნობ და მიხარია ბევრი თქვენგანი გავიცანი კიდე და ეს პირადად ჩემთვის და ზოგადად ჩვენთვის ეს ძალიან მნიშვნელოვანი და საინტერესოა თუნდაც მხოლოდ ამიტომ და მე აქ-იქში გადაშიგ როგორც იტყვიან ვუგდებდი ყურს მოხსენებებს და მე მგონი ძალიან საქმიანი და ძალიან ესე თვითარებაში ჩაიარა დღევანდელმა ჩვენმა სიმპოზიუმმა რომ ეს არ იყო უბრალოდ კრება დარჩა მხიარული ხო როგორც ერთ-ერთი გავარაკშია მე ნახა თქვენს ნებართვით მე ჩვენს უცხოელ მეგობრებს გადავცემ ამ სერტიფიკატებს და ამავე დროს მინდა უთხრა მათ ჩვენე გარდა სერტიფიკატისა პატარა პრეზენტიც გაუმზადეთ მათ ეს არის მე არ ვიცოდი და სულიად შემთხვევით აღმოჩნეთ ქართული ანბანია ძალიან კარგად გაკეთებულია და ქართულ ინგლისურად არის მერე განმარტებისად გაკეთებული რა ქვია რომელი რა ასვა და აქვე არის პატარა ტექსტები ასე რომ ერთგვარი თვითმასწავლებელიც არის ეს არ არის მხოლოდ ეს რა ქვია გამოსაფენი რაღაცა საჩუქარი ხო და იმედია რომ ჩვენი მომავალ წელს ეხლა ვის გადავცემ თემას ბატონი სურენდრა უგალე ხო და მე დარწმუნებული ვარ ბატონო სურენდრა რომ მომავალ წელს at last time your speech will be in Georgian because it's Georgian book.
I'm going to try. Thank you so much. Very nice meeting you.
And wine, where is wine?
Oh, we all like this?
In Georgia wine, ეს არის ჩვენ სახელზე ჩამოსული უნივერსიტეტის სახელზე ჩამოსული ვინოა და please.
Thank you very much. Thank you. Thank you very much.
Mr. Imran Abbas.
So much time. Thanks so much.
Please.
Manana, come here. The girls.
Yes.
Thank you, Manana. Stand here. Yes. Thank you, sir. So much.
ბატონი ხასან ბეგი სული ჩაუდგა ყველაფერს ემასთან ხარისთან ერთად
ხასან ბეგი
ეს არის ჩვენი ერთ-ერთი
სადაც
სპონსორი და სული ჩამოგვია ამ თვითონ კონფერენციის
Thank you so much.
დანარჩენი ბატონები უბრალოდ მე რა გვიან შემოგვიერთდებიათ ვახშამზე, გალა ვახშამზე.
ხო, გავხსნა.
რა თქმა უნდა, სერტიფიკატი და ყველაფერი ბატონ ხარისს ცალკე ელოდება.
ხო, უთარგმნე და უთარი მისული.
Dr. Harris, for you, we have certificate, all these...
We sent them.
Yes, presents for you. Thank you.
Thank you.
Thank you very much.
ეხლა სერტიფიკატებზე რომ მოგზანდებით, არ მოითხოვოთ თქვენც ეხლა ღვინო ქართველებისთვის არა გვაქვს ღვინო გაფრთხილი.
მაგ საღამოთი ვახშამზე იქნება, არ არის პრობლემა. Dr. Harris, thank you very much. Thank you for your attention, for your for organization this congress. It was very, very, very nice and very important for us, for all us, and we are waiting you in Georgia next time. Okay.
I will come for sure. Thank you so much. You've been very kind to me.
Good luck.
ბოლო თხოვნა მაქვს, რომ ერთი სურათი გადავიღოთ აქ ყველამ ერთად, ვინც არის დამსწრე. ძალიან დიდი მადლობა, რომ ამდენი ხნიან იმას თვითონ კონფერენციას აი ესე აქტიურად დაესწარით. უღრმესი მადლობა ყველას. Thank you very much, Haris. I'm so proud to have you as a friend and call you as a friend. Thank you. This was great collaboration and great experience. Thank you very much. Thank you.
Thank you so much. I've really enjoyed it, and it's been an amazing meeting. Thank you.
Thank you.